A wonderful starting of the CME and workshop with this chill winter day. Good morning to all invited faculty and delegates. Department of Anaesthesiology and Critical Care KGMU is organizing ACMO CME and workshop with collaboration of Medicine Department and with great effort of CTVS Department. This one is a second national conference on ACMO. We have a great experience with previous one, and our invited faculties are expert and have a lot of experience in the field of ACMO. So I hope this workshop will be great learning and experience for all delegates. I wholeheartedly welcome to all you, and we will start with first lecture, introduction, physiology, indication, and type of ECMO, and it will be discussed by Dr. Atiharsh Mohan sir. And he is associate professor in SN Medical College, Agra. He has done ECMO fellowship in Royal Pepworth Hospital, Cambridge, UK. Over to you. Welcome, sir.
Good morning, all of you. I quickly thank the organizers, especially Rajesh, Rati, and I met some new other faculties as well. And in fact, I welcome you all for this ECMO kind of awareness program or education. I think we are living in the ECMO era, and it's really I'm thankful to you that you have taken out your spare time and come here. Hopefully, we'll do justice and we'll give you a ECMO update and how we are, how the world is going on ECMO. So I think there's another scare coming in the form of human metapneumovirus. As we are aware, I think new viral surges are there. So many new diseases are coming up. By the way, anybody planning to go to China? I guess not. Okay. So I think the idea is, or what the message is, we are living in a disease-prone world. I think we all know as ICU trainees or ICU doctors, patients come with it's just surge of infection. They have a history of previously fit and well, and they just go downhill. They just come with hemodynamic collapse. They have really bad ARDS, and as clinicians, I think we don't actually make diagnosis at that time. All we are doing is supportive treatment, and that's what we do. I think when the patient comes with really bad ARDS or severe respiratory failure, we just resort to this ages old ARDS net protocol. We kind of use the Berlin's criteria, classify them according to the category, and then we just obviously we rely on low volume, high PEEP. Then we prone the patient. But you know what, we are all aware, but sometimes it's just not enough. This is an important slide that when we are resorting to low volume, high PEEP, what the high pressures can actually do to the lungs. So this is just after 20 minutes of high intensity ventilation, what the lungs become really edematous, and that's why some patients where we use really high low volume and high PEEPs, they actually succumb to the kind of iatrogenic or hospital. So is the conventional management okay? We can get away with sometimes, but does it always work? I think the answer is clearly no. And that's where ECMO is coming out really big time. ECMO machine, it oxygenates the blood, it removes the carbon dioxide, and it can also be used to give hemodynamic stability. Categorically, ECMO can be divided broadly into two types. So veno-arterial ECMO, it supports the heart and the lungs. And the VV ECMO, which is commonly called as respiratory ECMO, it supports the lungs, it helps in the respiratory failure situations. Obviously, we have hybrids too, where we use VVV or VAV. I'm not going to discuss this right now because I just don't want to confuse you. Broadly, it's VA ECMO to support the heart and lungs, and VV ECMO supporting the lung functions. There's a circuit. So there's a pump which is needed to get the blood out of the system into the oxygenator. Oxygen goes into the blood, carbon dioxide comes out, and that blood goes back into the patient. And there's a heater or a cooler to kind of regulate the temperatures of the extracorporeal blood flowing. This is how your ECMO machine looks like. This is a console where there's a monitor. You can see the flows. There's a pump. There's an oxygenator. There's a heat exchanger. And obviously, there are circuits coming out from the patient. Bedside, it looks where this is a VV ECMO kind of the patient is on VV ECMO support. where there's a 19 French, 15 centimeters, venous, this is a return cannula in the IJV. There's a 22 French cannula in the right femoral vein, and the patient is already on ventilation, but obviously it's not working. That's why the patient is on ECMO. So the idea of ECMO is to get or drain the blood into the pump to oxygenate, remove carbon dioxide, and get it back into the system. And as we have already seen, categorically, it's into two types. So if you take, or if the drainage is from a big vein, considering as a femoral vein, and if you return it back into the vein, this is the veno-venous system. You can choose the femoral vein as well. This is a fem jug, where you use the femoral vein as a drainage and the return into the internal jugular vein. But you can use it either way. All you need is like a big caliber vein, because the cannulas are really, they're quite huge. They're like 25 French, actually. So veno-venous is like taking out from the vein and delivering it back to a vein. And veno-arterial is taking out from the vein and delivering it into the arterial system. So that's the difference between the two. So ECMO is, as we have seen, so it helps in, the functioning of ECMO depends on the functioning of oxygenator, how much the oxygenator is actually, getting or infusing the blood which is flowing into the system with more oxygen, and taking the CO2 out. As we know, the CO2 solubility of CO2 is like 20 times more than oxygen. So this is more like kind of, it's more with the diffusion coefficient. The CO2 just goes on the sweep. Sweep is like, we use like 2 to 3 liters of, oxygen coming into the oxygenator, and that takes the CO2 out. But with the oxygenation, it depends on the efficiency of oxygenator plus the amount of flow of blood actually going into the machine. So it's very flow dependent. The veno-arterial ECMO, it can be done two types. In the ICU, we normally do it peripheral route, but if it has to be done in the theaters, the surgeons can also put central cannulas, and this is just a pictorial diagram to show that if the cannulas are placed directly into the heart, where you take the drainage from the right atrium and put it back into the aorta, it's very invasive. It's done by the surgeons. But if we talk about the ICU kind of settings, you take it from a big vein, which is usually a femoral vein, and give it back into a femoral artery. That's a kind of a peripheral cannulation which we resort to in the ICU settings. The pump of the ECMO machines, normally if you have CRRT machines in KG, I'm sure you must have seen the roller pumps. Roller pumps are not used for the ECMO machines because at very high flows, because in ECMO you have to go with the flows of like 3 to 7 liters. So that's the kind of flow you want to aim at if you're trying to aim for a good oxygenation. So we normally go for centrifugal pumps in the ECMO machines. They are associated with less destruction to the blood cells, so lesser hemolysis, and it's better. It helps in the hemodynamics in a better way. This is the mechanics of the oxygenator, where you have polymethyl pentene fibers, and the blood, and basically the science behind it is just simple gas exchange through diffusion. So as the blood is flowing through the fibers, oxygen goes in and the CO2 comes out. As simple as that. So oxygen delivery in a patient with ECMO depends on two things. It's how much the blood flow is going in the ECMO machine, or through the oxygenator to be precise. And when the patient is on ECMO, it's not that the native heart or the lung functions is not there. It's just, it's basically at that moment it's crap. But you have to take it into account at the later stages, because the more the time patient spends on ECMO, the native lungs, or the idea behind putting the patient on ECMO is actually give the lung rest. So as the patient improves, this function starts improving, and then you start reducing the ECMO supports and all. So it's you just keep it in mind that two systems are going on in the patient, but it's just one system is dominant on the other. Exchange of oxygen in the ECMO machine, we have to just remember it's more flow dependent. More is the flow of the blood into the ECMO machine, more will be the systemic oxygenation we can measure in the ABGs. Exchange of CO2 is not that flow dependent, as I said before. It's more, gas flow rate, which is like 2 to 3 liters or 2 to 5 liters that we can use. It's called sweep gas flows, and the science behind is that carbon dioxide is actually more soluble as compared to oxygen, so it diffuses out actually rapidly. Now we have a pump, we have an oxygenator, and there's a patient. So what's the connection? Obviously, it's the cannulas. So the drainage cannulas are the important entities. And when the flow, what we are talking about is actually in the range of 3 to 7 liters, we need really high bore, or they are quite thick cannulas. According to the traditional Poiseuille's formula or the theorem, I think the cannula should be large bore and short, but just because of the risk that they should not accidentally come out, because that will be like very, very catastrophic to the patient. They're not very short. We have to use larger cannulas or long length cannulas so that we just cut the risk that they accidentally come out. Use large bore but relatively long cannulas so that they sit pretty inside, so that they should not come out during regular nursing or physiotherapy or simple mobilization of the patient. So we use for the venous drainage, we use 25-55, which is 25 French and 55 centimeters in length. That's the normal that we use for drainage. And for the return, we normally use 19 French and 15 centimeters, so that it sits right in the SVC just above the RA. That's a normal kind of practical what we normally use in the ECMO patients. Cannulations, as I said before, it can be done by percutaneous route if you are properly trained as an intensivist. You have slightly different dilators, but as I said, they're it can be the patient has to be anticoagulated. It can be a little tricky. Some centers ask the surgeons to do it like a kind of open. So both the routes are kind of feasible. It depends on the efficiency. So this is so it can be done both ways. When we are thinking about putting a patient on ECMO, the important thing is why the patient needs ECMO and when the patient needs ECMO. So we have to kind of decide whether the patient need for ECMO is respiratory or cardiovascular or the hemodynamic collapse or kind of both. So we have to recognize the need, why the patient actually needs to go on ECMO. Is the process leading to the failure reversible? Is it reversible within a reasonable amount of time, or is it kind of irreversible forever? And if it's not reversible, then are we thinking about a transplant? I think these are the questions which we have to ask ourselves and discuss among the team before putting the patient on ECMO. You just don't think about ECMO in all the patients. So it's very important to know that ECMO is a bridge. ECMO is a bridge to recovery from acute reversible illness. It can be a bridge to transplant if your center supports it. It can be a bridge to bridge if a patient needs a heart transplant, but the heart is not there, but you want to put the patient on LVAD or a BiVAD, then it's fine. But if it's like a bridge to nowhere, never use ECMO. So veno-venous ECMO in today's setting, I think it's coming out as one of the foremost therapies for acute respiratory failure with super results. I worked in Cambridge, I worked in a Papworth hospital. I've seen 80% survival, and I'm not inflating I'm not giving you the bad, just inflated figures. I've seen 80% patients surviving and coming out from the, especially from the respiratory ECMOs. VA ECMOs are a bit tricky. It's more surgical, but VV ECMOs, if things are done well and in time and with the right protocols, the survivals are there. As we have seen, there's a Murray score which can help in selection of the patients who can actually qualify, or you have to kind of think about the patient may need ECMO support. And for the Murray's score, what the normal parameters are there, you just take into account the PF ratios. You check the chest X-ray, that how many zones are involved. You take what PEEP they are on, and you check the compliance. And if the patient is triggering a score of more than 3, then that patient actually qualifies to go qualify for ECMO support. The most common indications for the VV ECMO are, so the key word is reversible. The process, whatever the patient is having, is either reversible, or we should have a definitive aim, what we are aiming at. Be it lung transplant, that's fine. If your center is not doing it, don't do it. But if it's like a indefinitive or the process is not reversible, never ever go for ECMO. But the most common indications where ECMO is actually working is any reversible acute respiratory failure, failed lung transplant graft. Even it's advocated to be used in pulmonary contusions after trauma. It can even be used in pulmonary embolism settings. For VA ECMO, we can use it in cardiogenic shock with or without MI. We can use it in fulminant myocarditis, which is very common these days. We don't know whether it's viral induced, but it's just getting very, very common. And it could be a cardiac arrest due to query cause, but it's kind of a witness cardiac arrest where we know that the patient hasn't had a neurological injury or hypoxic injury. They are the patients who actually qualify for ECPR or post-cardiac arrest. And it can be a bridge to decision for transplant or LVAD or BiVAD therapies. Now, when you don't have to go for ECMO, when you absolutely know that the process is irreversible. Never ever go for a this ECMO therapy. And if the patient is like having a malignancy which is like non-curable, liver cirrhosis, it's kind of a relative contraindication. But I think just because of the associated problems with it, don't go for patients who are already cirrhotic to start with. Even the ventilator, I mean, if you are too late in the process, I think there have been numerous studies where it has been shown that the patient has been triggering a score of, Murray score of more than 3, and the patient has had, very high pressure ventilations for more than 7 to 10 days. So these are the patients who actually don't do well on ECMO. So I think the time frame is very important. You have to, be within the limited time frame, or the right time should be there to, decide whether the patient actually needs ECMO or not. And if the patient is like irreversible, if the patient has had, a cardiac arrest, or, having a suspected hypoxic injury, I think these are not the candidates where you should actually go for ECMO. There has been a notion, or there has been a mindset where we kind of, associate low platelet counts, and we kind of think that the patient might bleed when they go on ECMO. So I think with the recent studies, it's been shown that even in patients with low platelet counts, and especially in the tropical infections and, pulmonary hemorrhage kind of situations, we actually should select out and not exclude these patients to get ECMO. And these are the patients who actually do well on ECMO. And some general contraindications for the VA ECMO is, again, the bottom line is the same. If the primary disease process is non-recoverable, don't go for ECMO. If you don't have a transplant center, if you don't have a definitive therapy in place post VA ECMO, don't go for ECMO. Then if the patient is like morbid obese, more than 120 kgs, these are the patients who have mobility and other issues. These are also the patients who actually don't qualify for ECMO. And again, unwitnessed cardiac arrest, when we are not sure how the patient's brain is like to start with before the ECMO therapy. So these are the patients who are generally excluded from getting the ECMO. So the goal of ECMO is either recovery or bridge. We should never go into that plane of in a nowhere zone. It has to be a recovery. There should be a plan when we are initiating the patient on ECMO. And the idea is obviously keep the patient alive. The patient is going downhill. We have to save him. And when we are doing that, obviously we are ensuring the organ rest. So it's just a support therapy. It's not a therapeutic, ECMO won't do wonders. What it does is it keeps the patient alive. It buys time for the primary organ to recover. And what it does is it just helps the body and the other organs from failing as well. Ventilation strategy, a word about it. I think what's important is that when we have already initiated like 2 processes for oxygenation, now what we should ensure is we should ensure the organ rest. So if we are talking about the respiratory ECMO, now we have to go for settings where we can just ensure the organ rest. But at the same time, I'll just like to make it clear, don't knock it down. That doesn't mean you just paralyze the patient, put the patient on ECMO, don't do anything. Our lungs will be literally, they'll be shit actually. They'll be just soggy, they'll be like solid. So what we have to do is just kind of, just keep them open. Just give them rest to recover, do bronchotoileting, go for ultra lung protective kind of ventilation strategy, which is a pressure controlled mode. Just go for a respiratory rate of 8 to 10. Aim for peak inspiratory pressures of less than 25. Keep them open with a PEEP of 10, and just give them low FiO2s, because rest of the job is being done by ECMO already. So what we are ensuring here is just lung rest or the organ rest. The other thing is, as I said before, the oxygenation when the patient is on ECMO is totally flow dependent. More is the flow, more will be the oxygenated fraction coming out from the machine, and more will be the systemic oxygenation. So ECMO is very, very flow dependent. Now, these flow dependent strategies are very, very patient specific. You have to just kind of, if for the VV, if we are doing a VV ECMO in a patient, all we have to do is you have to target the flows so that we kind of, have acceptable saturation. We don't want a saturation of 99% in these patients, but we want a kind of, 85 to 90 kind of saturation where the other organs don't fail, and we ensure good recovering time to the lungs or the primary organs affected. Similarly, for the VA ECMO, we target flows because obviously your flow is going in the arterial system. So we just target flows where the other organs are getting the, we just measure all the indices for the end organ perfusion, and we just kind of make sure, okay, the heart is not working, but we have ensured something which is maintaining the adequate perfusion for the other organs and preventing them from failure. So that is important. So ECMO is not like, you just go with the, you just go with the zeal and, put the patient on full ECMO therapy. So you have to kind of, select out, you have to just go slow. So start slow, choose your indices, settle for the lesser kind of acceptable, ratios, because the more is the flow, more are the complications, more will be the turbulence, more will be, the chances to get the clots, and more is the, the oxygenator subjected to getting more clots and getting clotted. So I think just go slow. The idea is to just support the other organs and maintain, keep the body alive, and at the same time just ensure organ rest, primary organ rest. So the targets of flow, as I have said before, target the lower acceptable saturation values for the VV ECMO. For VA ECMO, again, just ensure that the end organ perfusion is kind of in check, but don't go for like superboard or overboard kind of conditions. When the patient is on VV ECMO, there are usual complications which will be talked about more in the troubleshooting and complications by my other colleagues. But just remember, there's something called recirculation, because I'll just show you. So there's something called recirculation where when both the cannulas are in the major veins. So if you can see, so this is the drainage. This is the return cannula, and this is the tip of the drainage. So both the cannulas should not be very near, because once that happens, what happens is that the ECMO machine is just working in a loop. So whatever comes out in the drainage is actually returned to the cannula, and it's not being delivered to the systemic circulation, but it's just flowing back into the drainage, and that's called recirculation. So we have to kind of limit these things. We have to just ensure that there's an adequate, gap, which is actually more than at least 10 centimeters. And sorry, this one, yeah. So you have to just keep these things in check, because, and you know what? Sometimes the patient is kind of, the nurses just change the position of the patient. They might just do a head up, or the patient, having a pass stool, and just he's having a wash. And these things, the cannulas can migrate, because the negative pressure in these cannulas because of the pump is actually so huge that don't assume that these cannulas don't migrate even after 5 or 7 days. They can migrate. So these are things which we have to check on a regular basis. Similarly, there's something called Harlequin syndrome, where you start a patient on VA ECMO. This is the peripheral VA ECMO. And when the return, sorry, I'll just show you this. So this is the return from the ECMO cannula. So this is the return in the femoral artery where the blood is going in, and this is the native heart pushing the blood into the aorta. So when the ECMO was started, the heart was not doing well. But over the course of maybe 5 or 7 days, when the heart has actually started working good, this native circulation starts fighting with your artificial circulation. And if the lungs are not doing very well, due to query cause, if like they have got infection or maybe they are fluid overloaded, then what happens is this native circulation is actually hypoxic. I mean, less with oxygen, but this is like flushed with, with oxygen, because this is coming from the oxygenator and from the ECMO machine. And what we get here in the body is actually the upper region of the body is actually hypoxic and appears blue or cyanotic, and the lower region or the lower half is actually pink. So this is called the north-south or the Harlequin syndrome. So this is what happens in the recovery phase. So we have to kind of take into account all these things. So when the patient is on ECMO, we have to do a very, very thorough monitoring, and we have to kind of know that there are two circulations which are going on in the patient. There's a native circulation, and then there's a ECMO which is doing to the patient as well. So I think we should not be confused. So I think what we do in the ICU, we should just keep on managing that. Hug your patient fast, but do it twice a day. So you keep a check on your feeding, analgesia, sedation, thromboprophylaxis, head up position, ulcer, glycemic control, spontaneous breathing trials, bowel care, whatever you do, as you do for all the ICU patients. But apart from your clinical monitoring, what you do for all the patients, what's important in the ECMO patient is that you do a regular circuit checks as well. You do the normal, you check the circuit pressures, because they tell you a lot about what interventions, what's needed to be done if the patient is on ECMO. You check your flow rates. If the patient is having, some changes in the flow rates, that means that something needs to be done in the patient. Then in the circuit check, your nurses have to be taught to check for regular clots, any disconnections, kink or air. I mean, if a patient has got disconnected or if there's a major air entrainment in the system, I think the patient will die in seconds. So these are the complications which just can't happen if the patient is on ECMO. Lab monitoring, I think you do your normal labs, you just check for the end organ, perfusions, you check for your lactates, you do your normal electrolytes, you treat your normal sepsis as you do. But apart from that, if a patient is on ECMO, because they are on a lot of anticoagulants, because as I said before, ECMO is like equates to flow, and when there's a flow, there's a turbulence, a lot of tendency to form clots. So what's important is that you keep a regular check on the coagulation parameters. And apart from that, you also do regular lab testing or radiological testing on how your affected organ is kind of behaving or coming back. You do normal repeated echoes, you do you do a CT scan, you repeat how the lung functions is recovering and all that. So management of oxygenation is that you correct the causative factor, you control the recirculation, you check for the improving organ recoveries. If there's a increased cardiac output, that means the ECMO machine has to work more, because the recirculation fraction actually goes up. If your patient is having a cardiac output, you have to keep the cardiac output down, you have to check their temperatures, you have to sedate them thoroughly, and that's what affects their oxygenation as well. Tips on anticoagulation. Normally, the activated clotting time, we normally keep in the BV, we keep it around 160 to 180 seconds. But in the VA systems, we normally keep for 180 to 200 seconds. HITS is not a very, very unusual or a rare thing. I think it can happen if a patient is on unfractionated heparin for long. So you have to just keep a watch if the patient is developing HITS. And in that case, ergatroban is, I think, the drug of choice. But it should be kept in use. Sedation can be an issue, because if a patient is on ECMO, you have to just think about that the volume of distribution of this patient has increased to, because there will be a lot of drug sequestration. Lots of our drugs which we commonly use, like propofol, are sequestered, or it clogs the system, especially in the oxygenator. So you have to just check your drugs. Sometimes the patient is on ECMO on humongous drug concentrations, but you have to keep them sedated, because as I said before, you have to keep the cardiac output in check. You have to sedate the patients. There are anxiety issues. The patient on ECMO are very restless. They are and sometimes out of anxiety and restlessness, and not necessarily you have to paralyze all your patients. If they happen to take the cannulas out, it's instant death. So you have to keep them sedated, keep the LA, the anxiety, no restlessness, keep the cardiac output down. And so sedation is something which is very important in these patients. Nutritionally, I think in ICUs, we normally, resort to a 25 to 30 calories per day, per kg per day kind of a regime. But the patient on ECMO, they are extremely catabolic. And sometimes in these patients, we have to go for a calorie intake of 60 to 90 calories per kg per day, just because of the high catabolism that they are being subjected to. And apart from that, it just poor nutrition can just increase the chances of susceptibility to infection. It increases the mortality. So nutrition is something which we have to really, really take into account when the patient is on ECMO. General nursing care, again, I think nurses are the major hold if we have to take the patient out of ECMO. So proper eye care, proper skin care, regular physiotherapies, and obviously bowel bladder care, and change of lines and catheters. We have to be very, because when the patient is on ECMO, there's a lot of negative, high power negative system in the blood, just because there are pumps getting or sucking the blood out. Even if a port of central line is kept open or left open for some time, there will be a massive air entrainment. And believe me, the massive air entrainment is like the loss of the pump will stop working and the patient will die straight away if he's very, very ECMO dependent. Apart from that, if the patient is being offered physiotherapy, the nurses have to ensure that the cannulas are secured, the cannulas don't accidentally come out, they don't develop any kink, there are no disconnections, and they have to regularly monitor for recirculation or Harlequin syndrome or any kind of desaturation. Because obviously, as we know that if a patient is on ECMO, the native circulation or the native organs are definitely they are perilously they are in a peril. I mean, if the ECMO stops working for some time, obviously they'll die. So all these things have to be taken into account on a very, very regular and 4-hourly kind of basis. The other thing is, obviously, ECMO is nothing but a machine. So it can develop snags. It can develop a pump failure. The oxygenator can have a failure. The oxygenator may just have a big clot and just stops working. There may be a massive air entrainment. And during cannulation, cardiac perforations are not uncommon if you're not careful. So you have to be very careful about, even if it's there, you have to obviously just keep a surgeon at bay, and the patient may need even a sternotomy or a cardiac surgery. So I think these are things which we have to really, check into account and take care of if a patient is on ECMO. Apart from that, circuit clotting, hemolysis, all these things have to be checked on a very, very regular basis, because the blood flow, and I said before and I'm repeating it, ECMO is very, very flow dependent, and more is the flow, hemolysis, clotting, these things just increase to altogether a different magnitude. Apart from that, the patients are usually on unfractionated heparin, and the patients may develop visceral bleeds, they have a cerebral bleed, so these things have to be taken into account as well. The other thing is, sometimes these patients, just because of the big bore of the cannulas, these patients can have distal limb ischemia or even end organ failures. I think it's a dictum. 60 to 70% of the patients on ECMO can have renal failure. They usually land up on CRRT therapies as well, being on ECMO. So simultaneously kind of CRRT therapies. But this is something which just comes with the play. I mean, it's just risk versus benefit. So check for infections. Just because they are big pipes, it's big plastic pipes sitting in the system. So the patients can have central line associated infections and systemic infections. So everything has to be taken into account. Apart from that, I think a patient on ECMO, he's so much in pain. Sometimes they get delirious. They are so fearful. So these things has also to be taken into account. They have to be comforted by the team. They have to be talked, because they are conscious. They just feel as if they feel that something is really wrong, but they are conscious. So I think that psychological support and the motivation has also to be taken into in the therapeutic or in the therapies. So it works as a team. So does ECMO work? I think we all will agree yes. But so she's Esperanza. I think she got her ECMO she had a cyanotic heart disease. She was on ECMO support, and she's till date. She's the mother of 3. She's almost 49. So she's her name is Esperanza, which is hope in Spanish, and so she's the first survivor of ECMO. So ECMO is not new. ECMO was there in the 1970s. So what made it come again or go off for some time? I think it was a selection of patients which was probably in those times. I think it's something which we in our generation has faced with NIV and elective ventilation. So I think it's synonymous to that they were putting the patients late. I think previously they were putting more of VA ECMO support, which is tough, or it has bad results anyways. And they were just choosing the wrong category of the patients. But I think both trials have little relevance to the ECMO results now. And I think this is the CSER trial, which was published in 2009, which has just changed the ECMO practices worldwide. So it's a conventional ventilation or ECMO for the severe adult respiratory failure trial, which was published in 2009. And this has just, given out results that ECMO, if applied at the right time with the correct protocols, it just gives wonderful results. This is also published. In the ALST registry. I think the number of ECMO patients post CPR in the respiratory infections or respiratory ECMOs and the VA ECMOs, I think the number is just increasing, and the results are also quite encouraging actually. This is a good study which was published in JAMA in 2011, where they have made a very positive inclination towards using ECMO, where if the ECMO is if the patient is referred at the right time, right protocols, and as I said before, high pressure ventilation after 10 days is generally futile, even with the respiratory ECMOs. So right time, early elective ECMO is having good results. Coming back to the first slide, I think we are all living in an era. We know some diseases are just surging. Sometimes it's COVID, sometimes it's some mutation, sometimes it's human metapneumovirus. I think the world has become such a small place. Anything surging anywhere in some small district in China is like everywhere. So I think given the scenario, I think it's time that we take ECMO as the next step in ICU. It provides optimum oxygenation, hemodynamic support to all the organs. It's not a therapy, it's just a support. What it does is physiology restoration. It buys you time. It keeps the person alive. It's no treatment, it's just support. So timing is the key. And we have latest evidences coming that ECMO really works. So should we go for ECMO in all the patients? I mean, if a patient lands up in the emergency and you are working there as a duty doctor, should we just think about ECMO, the patient wheels in? So that's not the idea. So you start with the conventional therapies because you know what, ECMO has got its own problems. It's very invasive and it has its own merits and demerits. So this is a good trial which was published in 2018 and in NEJM, and where they said that there's no exceptional advantage of using early ECMO versus late ECMO. So you have to start with conventional therapies. You do what you do. Don't jump on ECMO, but at the same time, don't jump too late on it. So it's kind of a learning lesson. It's a kind of a learning curve which we all are going through. So don't jump on it. At the same time, don't get too late on it. So remember, ECMO is a therapy where we have to have a definitive or a recovery process in mind. If the patient is having a bridge to nowhere in a patient for ECMO, it's an absolute no. Take home message, especially for the young budding intensivists. It's not a support. It's just a support, not a therapy. So never take it as a therapy. It's a very and it comes with its merits and demerits. Selection and timing for the ECMO is the key. It gives you the results. It's a team decision. It's not what I think. It's like the complete team thinking together. It's a team effort. You need skilled doctors. You need skilled nurses. You need a lot of perfusionists. It's 24/7 job. And mind you, some patients I have seen on ECMO for a year. I think the lady walked out postpartum COVID ARDS. She walked out of the hospital after a year of ECMO. But yes, it happens. It can happen if we all work together. And continuous training and reflective learning and organizing conferences like this is the key to it. Thank you so much. Thanks. This is our ICU in SNMC, which we have started in July, and so we are thinking and trying our best to get ECMO here, and we are soon starting ECMO services, probably March. But thanks. Cheers.
Thank you, sir, for comprehensive lecture. Just I want to add one point regarding physiology of this. We have to maintain DO2 and VO2 ratio. It is basically delivered oxygen and consumed oxygen ratio, and it should be more than 3:1. I'm right, sir? And if it is below, then there will be a metabolic acidosis and all problems can be happen. So just I want to congratulate Dr. Karan Kaushik. He is senior consultant in Medanta, and Dr. Karan will take a lecture on circuit component configuration, and basically this topic is important for us because every patient have different type of physiological status, different cardiac output. We have to decide what type of cannula is required, what will be rated flow of oxygenator. So again, this topic is very important. Please listen carefully. Welcome, Dr. Karan.
Thanks a lot, ma'am and Raman sir, for giving me such a warm welcome. Good morning to all young enthusiasts. My topic, I have tried to make it as simple as I can. Whenever we see any components or hardware, it's a basic reflex to fall asleep because this is more of a practical work. But please believe me, only interesting parts I have kept in the topic. Rest will be discussed in detail in the workstations, but each part of it will be needed to enjoy the workshops actually. So whenever we hear about ECMO, what all it runs in our mind? Mortality is very high. Are we trained enough? And it's lots of high-tech stuff. But it's not so. It's quite simple with few principles. And whenever it hits your mind, are we trained enough? But that patient and that family, their fate is entirely dependent upon you. So it's never late to take a call. So these days, this is the era of the medical revolution. So as Sir told, it's a bridge and a fantastic bridge for a lot of things. And purchasing from few hours to a month of life to a patient for you to do wonders. So the father of ECMO, who actually did the case, which has been very well explained to you, the first congenital heart disease, and she is doing now great. And this is the first setup, initial setup, what was used with the components you can see, such as simplified components on the right side. And this far we have evolved to just a small monitor, very beautiful, handy monitor, which you can run away anywhere with it. So let's understand the machine, right? So this is your basic VV ECMO. I will just explain. So you extract the blood from the body, that is from your drainage cannula, right? You insert a good sized drainage cannula from your vein to harvest the blood, and then the blood goes through your pump to your oxygenator, and then from the oxygenator back to any part of your venous drainage. Most commonly used is your SVC, and from the SVC again to the lungs, to the heart, and the full body, the oxygenated blood, okay? But when you drain from here, it is extracting mainly the blood below the diaphragm, okay? So the hardware equipments that are involved in it, the pump unit and the drive console, basically the thing with which you can control the speed, RPM, like a fan switch, okay? And the heater unit, like similar one that you use in your bypass machine, the air oxygen blender, the similar fashion as your bypass machine, and the hand crank again in a similar way, and a sprinter cart. Sprinter cart is what which carries your machine on the wheels. That is your sprinter cart. Okay. So this is your console. These are the two things. The previous one we used to call it as a cardio health. Digitalize. This is the era of digits. So this is a digitalize and compact. The recent one, Rotaflow 2. This is your sprinter kit. You can move it anywhere. And this is your console drive. Rotate the knob to adjust. This is your heater unit. It heats the RO water as per your requirement. Fine. Okay. So then comes the disposable that you have to manage with the patient. The cannulas, or of course, the Rotaflow, the disposable pump, the oxygenator, with the heat exchanger inbuilt and the tubings with the connectors. So this, the smaller ones, the red ones are your return cannulas. They return the oxygenated blood to the patients. The larger ones, blue ones, are your drainage cannulas. They drain the blood. This is your PLS set, okay? That has this oxygenator and heat exchanger fibers built in it. From here, the connections for your water to heat up the blood as per your requirements, and the gas blenders, and this is your pump. So, just to summarize what I have told, your blood is drained and through the pump get into your this oxygenator, and inside the oxygenator your gases comes, oxygen enters and the CO2 gets washed out with the oxygen blender on the extreme side on that number 5. This just similar way as you have on your pump or on your anesthesia workstation, right? And after the blood gets oxygenated, it gets returned to your preferred site, whether it's a VA ECMO or VV ECMO or the different types we'll discuss. So there are few parts in the circuits that are important to understand. On the extreme right side, okay, you harvest the blood from here with the pump. So this part will be negative, okay. This is known as pre-pump or P1 pressure. And after you harvest, you mobilize with your centrifugal pump and push it. Then this is the oxygenator. This is a pre and the post. This is your pre and post, okay. P2 and P3. This is P2 is your post pump but pre-oxygenator, and this is your post oxygenator, okay. So we have to understand these 3 parts of the pressure, and we monitor routinely the P2, P3 in a separate monitor. Likewise, you do with your arterial blood pressure, you monitor on your screen. Similar way, you need another monitor in which you can mainly monitor these 2 pressures to calculate the delta P across the oxygenator, right? That will give you any obstructions across it. Fine. So this part is important. I repeat again, there are 3 parts in the pressures in the ECMO circuit: P1, P2, and P3. P1 is pre-pump, P2 is post-pump, and P3 is post-oxygenator. P2, P3 is the delta P that is required to check whether there is obstruction in the oxygenator in the form of clots, because definitely it has got some life, or your action of your anticoagulants, okay. And this P1 pressure has to be negative just to check whether this thing is functioning fine or not, okay. So next. So to summarize, your drainage satisfies your pump preload, and when you return, it satisfies your pump's afterload. And the cannula size and all we'll discuss now. So this is the drainage and the return cannula chart, okay. The size, like you define a size of endotracheal tube or you define a size of DLT, this is the chart to check the size of the drainage cannula and the return cannula. But believe me, it's hard to mug it up. So the easiest form which I do routinely is, you just see your vessels, okay. For example, you have to drain the blood from the femoral vein. You put your probe on the vein, see the diameter, okay. You have to return your blood to the SVC or the IJV, okay. You put your USG probe and measure the diameter. Multiplied by 3 gives you the fringe. It is the maximum size. We prefer the maximum size for drainage to take the maximum blood out, and the return that can be placed without any much injury. For example, on normal VV ECMO, you have to put the cannula into the femoral vein directly going up in the IVC. You choose to put a maximum caliber cannula. Check the diameter of the femoral vein, the minimum thickness multiplied by 3, you should choose your cannula. And again, the return you put on your IJV where you have to insert multiplied by 3 is the maximum size. Okay, you have to bargain between the injury and the size. Okay, this is how you go. Then percutaneous technique, I think all of you are the budding intensivist, anesthesiologist. It's mostly similar like you're inserting your central line with a sequential dilators, right? You have, this is very important step by step you have to dilate the vessel. And not to mention the another important component of an ACMO machine is torch light. Whenever you take a round, you have to get the torch light on the right side just to check, as sir has told, the recirculation. Okay, if the recirculation is there, the color difference will be not. Okay, you can get both same colors if the recirculation is there. The drainage cannula and the return cannula should be kept next to each other just to check the recirculation is not happening. The color should be contrast. It should be as black as red. And second, spray your torch over the oxygenator just to see such clots. If you are active enough, you see the delta P, the difference pre and post, it will say the pressures are increasing. And before that, if you have a torch light, you can see, okay, fine, we are seeing some clots. By afternoon or by evening, the delta P is going to increase. Okay. And next, before I jump over to the next important component, just to tell you about the two pumps, roller pump and centrifugal pump. Roller pump we routinely use for the cardiac surgeries inside the OT, and the centrifugal pump we use in the ACMO machine. And why so? The roller pump runs on a principle of like squeezing and pushing. Fine. If I try to push this wall hard without knowing anything pre or post, this is roller pump. Its action is just to give a push. Okay. सामने क्या है उससे मतलब नहीं है, बस दबा के प्रेशर देना है. It will create good pressure, but at a cost of few side effects like squeezing, hemorrhage, hemolysis. If the cannula is inserted wrong, it can cause dissection. Fine. And since the pressure is going on, if the return is not good, there is some air, it will catch the air also. But inside the OT, you are vigilant, you can see. But in the ICU, for the long days, 14 days, this can be catastrophic. So we innovated a centrifugal pump, keeping in mind all this stuff. We want a pump that has to be preload dependent, so that you don't have any lot of air getting into it, that have to be afterload dependent, so that it doesn't cause any catastrophe like dissection. And third and foremost, we have to do it for long. That has to be hemolysis free at the maximum, destruction free at the maximum. So there is a principle, the centrifugal pump, how it works is, with the ultrasonic sensor, it makes, like this fan is there, na? It rotates. So it makes the blood in this form with the minimum pressure at the center, maximum at the periphery, making a centrifugal force and pushing the blood out. Okay. The funda is the sensor, the pump console, jelly, which judges the flow. Like आप ultrasound करते हैं, देखते हैं vessels कैसा है, कैसा नहीं है. Same principle form में magnetic console रहता है. वो ब्लड को जज करता है आपके हिसाब से, जैसा रोटेट करते हो आप बटन को, उतना तेजी से विद द मैग्नेटिक कंसोल ब्लड को घुमाता है इस फैन के साथ. वो फैन को घुमाएगा और फैन ब्लड को घुमाएगा. ब्लड को घुमाएगा सेंटर में आपका नेगेटिव, इधर पेरिफेरी में पॉजिटिव, कैन कॉज विल कॉज अ पॉजिटिव फोर्स एट द पेरिफेरी एंड पुश द ब्लड अवे. बेनिफिट इज इफ देयर इज सम ऑब्स्ट्रक्शन अवे फ्रॉम इट, if some obstruction is away from it, it won't break it up. It is afterload dependent. The fan will keep on revolving in the blood. It will heat the blood. The kinetic energy will transform into the thermal energy without causing breakage away. And again, if some air gets entrapped, it won't function. The wings will be entrapped in the air. It is going to cause the damage, but not that much. And the third, it is not pushing or causing hemolysis. It is just rotating like a fan kept in the in a pool of water. Okay. So this is the basic funda. That's why we have approval of 14 days, and there is a minimum transit time, mean transit time, sorry. The blood period in the pump head, that is quite decreased with this centrifugal pump. That's why this pump is used for long days, even months. So this is the difference I told you already. It has to be afterload dependent and preload dependent also. So it causes minimum injury. Okay, you can afford some injuries at the cost of life. So the next important component that is actually important is the jelly, because in few centers, if you have a Rotaflow 1 and you see the saturation is falling, the pump is not functioning because the jelly is exhausted. At the console, the jelly is exhausted under the pump head. So the jelly is again a very important component if you are using Rotaflow. The falling saturation, pump not working, this is a magnetic console like USG, ultrasound probe. The jelly is not functional, it won't sense at what speed the blood is moving. Okay, so jelly is another important component, but Mackay, they have innovated a new technique for it, Rotaflow 2, which is recently used at most of the places, but still, till date, Rotaflow 1 and that previous cardio help is also used. But from now onwards, mostly centers you will have this Rotaflow 2. It have this external flow or bubble sensor and detector that helps us to read the flow of the blood. It doesn't need that jelly part. So they have innovated a new technique so that if the jelly is exhausted, there is no jelly, the patient won't die, right? But again, the jelly is an important component because in 70% of the setups, you will find Rotaflow 1. How much flows to keep, I think will be discussed in detail by ma'am shortly. We can go with the cardiac output and centrifugal pump I have discussed. If the preload increase and the afterload decrease, the flow will increase, and on the opposite, the flow will decrease. And as the Harlequin syndrome, north-south syndrome, when the heart contracts and the VA ECMO is there, it will cause against the contractility, the flow. So coming to the membrane oxygenator, it has the heat exchanger fibers in it, like your lungs, a pathway for the air, oxygen, a pathway for the blood, can exchange the gases, and the similar heat exchanger that you have machine, it heats up the RO water only, but you have to be specific that the temperature difference between your this machine and the body should not be more than 10 degree. Okay, that is the limit to avoid any hemolysis or trauma to the blood. Now, this is the oxygen and blender. A similar way that you have with your ventilator machines or your anesthesia machines or your bypass machine. Okay, so if you have to increase the oxygenation, you go with the FiO2, and if you have to clear up the carbon dioxide, you have to go with the sweep gas flow. The sweep gas flow is how much liter per minute the air is running across your oxygenator. Likewise, you set your flow on your ventilator. When you are using Bains, you do it 10 to 11. When you are using your closed circuit, you do it 2. The same. Sweep gas is here. You start, the cardiac output is 5 liter per minute. On the opposite side, you start at 5 liter per minute, but you need to wash out more CO2. You can get as high as 10. Okay. So the tubings made, they are non-toxic and non-irritant, soft and kink-proof. And to the top of it, they are coated with bioline. What is bioline? Some simple mechanism, some albumins and some covalent attached heparin that activates the complement system, that activates minimally your blood cells, leukocytes. It avoids activation of it. So that's why it comes with a shelf life of 14 to 20 days. So now the interesting parts are the configurations. So if we go with the configurations, the single lumen tube we all know. As I told, you put this drainage cannula, blue one long in your femoral vein, the tip just distal to your hepatic vein, and you put your return cannula in through the IJV into your SVC, entering into RA, directed towards the tricuspid wall, and you make a flow. Fine. But the new innovation to it is double lumen tube. The double lumen tube, what it does is you don't need two different cannulas. Let me tell you how. So there is a double lumen, an internal and an external lumen, okay, with the two ports, 1 and 2. The internal lumen goes distal to your hepatic vein. You insert one cannula directly through your IJV, and from your IJV, with the ultrasound machine, you titrate the distal tip should be beyond the hepatic vein. So the central lumen will extract the blood from here, will oxygenate it and return in the same tube to the other lumen. The outside lumen will give the blood directly into the right atrium with the hole here, okay, towards the tricuspid wall. Not very common, I don't think so, used in India right now. We have just read in the books only, not very popular also, because of the difficulties in insertion and the cost. So there are few configurations which are important. We have VV ECMO. Okay, VV ECMO is draining the blood from here, returning to your SVC, right? Then we have VTA ECMO to minimize the recirculation. We have some thin catheters can be advanced to the pulmonary artery, RA pulmonary artery, was the VTA ECMO, that is to reduce your recirculation. And then we have VVA ECMO, when you are in doubt that your drainage is less, vessels are bad, you are not able to extract enough blood. With the VA ECMO, you put two different drainage sites, one at the SVC, one at the IVC, and return it to the femoral artery. Then we have another one that is quite interesting in the ICU setups, that is VAV ECMO. We have a VV ECMO, right? We drain from the femoral vein, we return to the SVC, we have a VV ECMO. But if we have a patient, for example, patient of RDS, ARDS, who is in partly shock or NORAD supports, we are afraid that the patient might need VA ECMO also because of the failing heart. Then extra tube is inserted in the femoral artery. So our drainage is from your IVC, and the return is going to your SVC also and the femoral artery also. You can titrate with the clamps on the either way. If you feel like your heart is good, only lungs are compromised, you can clamp it. It will be converted into a VV ECMO for a ICU settings. And if you think you are now, along with the lungs, your heart is also down, the patient is on inotrope supports, you can clamp it here. It will get converted into a VA. And slight advancement of it is VA ECMO. Same, you have additionally inserted the right into the pulmonary artery with a similar fashion. So key to success, as selection of a right patient, as this is just a bridge. Second, initiation at the right time before the multi-organ dysfunctions develop. And utilization of right disposables and a regular practice. So, and a good ECMO team. So never be afraid of failures because they are just your way to success. Thank you.
So, if there is a VV ECMO configuration, so drainage cannula tip is in intrahepatic IVC and return cannula in common iliac artery. And if VV ECMO, then drainage cannula tip again in intrahepatic IVC and return cannula at the junction of SVC and RA. So it is very important in VV ECMO the distance between the tip of both cannula, and it should be 8 to 10 centimeter. If it is less than 8 to 10 centimeter, then there is a chances of recirculation. So every day we have to check the position of cannula tip and even at the site of insertion. Okay. Thank you, Dr. Karan, for comprehensive talk. Is Safali ma'am is here? I would like to invite Safali ma'am to felicitate Karan and other faculty of anesthesia department. Please join us.
किसकी है? नहीं कई नाम से एक से
Now we want to move another lecture. This one is initiation, management and monitoring and weaning from ACMO. And it will be delivered by Dr. Sikha Sachan. She is Associate Professor in Department of Critical Care Medicine, Regency Hospital, Kanpur. Welcome you, ma'am. Podium is yours. Welcome, ma'am. Is the pointer going to move?
So, a very good morning, everyone. So, while I was coming from Kanpur this early morning, braving all the fog, I was having an out of body experience. And it is really amusing that now here we are talking about out of body circulation, that is extracorporeal circulation, and really commend all of you that you even I guess it must be a half day for you all Saturday here, but everybody is here to attend this weekday workshop. So salutations to you. So after having learned about all about introduction of ECMO and indications of ECMO, where to use ECMO, where not to use ECMO, and also about the basic circuitry of ECMO, the various components. Now my job is to take you through initiation, management, monitoring and weaning. It is a fairly long topic and I will try to cover it in the stipulated time that I have been given. Now, what to expect from it. Once you decide to take the process of initiation of ECMO, you have to ask yourself that what is your expectation from the ECMO. You must remember, this has been repeated in the previous lectures also, you must remember that ECMO does not treat the lungs or the heart in question on its own. It just provides rest to the lung and the heart, so that, and artificially it provides adequate gas exchange and tissue perfusion, and this allows time for reversible recovery of the organ, reversible recovery of the heart or the lung, and at the same time it also minimizes whatever damage that can be caused to the patient by high dose of ventilation therapy or high inotrope or vasopressor induced organ injury. Now, prior to initiation, once you decide कि okay, चलो अब इस patient को हम क्या ECMO लगा सकते हैं, you have to ask yourself the following question: is the disease process life-threatening? Is the patient unresponsive to conventional therapy? मतलब अगर patient ARDS का है तो हमने patient को लिया lung protective ventilation पे, conventional prone ventilation किया या नहीं किया? Has the patient been unresponsive to this therapy? Similarly, if the patient was a case of let's say cardiogenic shock, is the patient unresponsive to your drug therapy? And third question is there any likelihood of organ recovery or not? And if the answer to these three is yes, then yes, you must go ahead with ECMO. But what if there is no likelihood of organ recovery? Then comes a tricky question, that is the patient a candidate for heart and lung transplant? The patient may be a candidate for heart and lung transplant, but you don't have facility of transplant at that center. You have no facility of transport of the patient to another center. The patient has financial constraints. Then in this case, the patient is not a candidate for ECMO. So indications, I'll quickly go through these indications. There are 6 broad category of indications: respiratory failure, cardiac failure, sepsis, transplant, prior to transplant, and elective short-term support to procedures. जैसे कि complex tracheobronchial repair होना है. In that case, you can offer ECMO as a short-term support, right? Or you have decided patient is a case of heart failure, heart का function optimal नहीं है. You have decided to go for heart transplant or even go for an LVAD, durable VAD, ventricular assist device. During that time, you can give ECMO to that patient as form of a mechanical cardiac support devices. And also a new thing coming up is ECMO CPR. Inclusion criteria, Atiharsh has already told about it. Respiratory conditions में क्या inclusion criteria है? Any 2 or more over a period of 4 to 6 hours after maximum conventional support. अगर इनमें 2 में से कोई भी positive 2 या ज़्यादा positive हैं, then you can strongly consider the patient for ECMO. Murray score. What is Murray score? Atiharsh told about it, I think. That this is a sum total of 4 essential parameters: PF ratio, chest X-ray, PEEP, and lung compliance. So if your Murray score is more than 3, then you have to strongly consider ECMO in the patient. बच्चों में Murray score नहीं देखते हैं, हम क्या देखते हैं? Oxygenation index. If mean arterial pressure and if product of mean arterial pressure and FiO2 divided by PaO2 is more than 30, then you have to strongly consider ECMO in the patient. For cardiac, again, if any of these 2 is positive, even after giving conventional support for a maximum time of 4 to 6 hours, then you have to consider mechanical cardiac support. So if there is sign of poor tissue perfusion before going to multi-organ failure, like low blood pressure, urine outputs less than 30, high lactate, less SCVO2, and altered conch, all these are signs of poor tissue perfusion. Or if there is refractory arrhythmias, जैसे कि Selfos का patient आ गया, the patient has started throwing. Adish, can you just please? Yeah. You can cut it, thank you. And if there is cardiogenic shock with a high inotrope score more than 20. So what is inotrope score? It is a score where a point is given for every infusion of vasopressor or inotrope that the patient is being given. So if the score, I have not included the INOPRO score, it's a cumbersome score, but there is a ready-made tabulation or software available where you can calculate the INOPRO. तो मेरा patient NORAD पे है, adrenaline पे है, milnirone पे है, कितनी dose पे है, इस सब का एक combination score होता है. तो अगर आपके patient का inotropic score more than 20 है, then in that case the patient becomes a candidate for mechanical cardiac support. But ECMO is not the only mechanical cardiac. I hope you all know that. That doesn't mean that you have to consider ECMO, but you have to also consider कि क्या ये patient मेरा IABP से ठीक हो जाएगा, या क्या हम इसको immediately कोई ventricular assist device लगा सकते हैं, या impeller डाल सकते हैं. All these things can we do. So just consider that ECMO is one form of mechanical cardiac support devices out of a bunch of numerous mechanical cardiac support devices present. Now, पहले क्या होता था कि सेप्सिस है तो बिल्कुल भी ECMO कर ही नहीं सकते, क्योंकि सेप्सिस में क्या होता था, अब सारी वेसल्स डायलेटेड होती थी, वेजो डायलेटेड स्टेट होती थी, हाई कार्डियक आउटपुट स्टेट होती थी. इन सब की वजह से एक अच्छा फ्लो माने ड्रेनेज उपलब्ध ही नहीं हो पाता था. तो लोग बहुत डरते थे कि हम जैसे ही पेशेंट को ECMO पे लेंगे तो पेशेंट क्रैश कर जाएगा. बट नाउ विद द स्कोप ऑफ ECMO एनहांसिंग, सेप्सिस, thrombocytopenia, all these things are no longer a contraindication for ECMO. ज्यादातर पेशेंट जो सेप्सिस के होंगे, they will need to be put on VA ECMO. क्योंकि क्या होगा, either these patients will have septic shock with severe myocarditis, or even if they don't have any cardiac per se abnormality, but they may be on very, very high inotrop support. उन केस में even if the lung has failed, that doesn't mean कि सिर्फ respiratory ECMO से काम चल जाएगा. If the patient is on very high inotrop support due to septic shock and he needs ECMO, he or she has to be considered for VA ECMO. But a small fraction of the patients who will predominantly have septic ARDS but with reasonably low support of inotrops, these patients can be considered for VV ECMO even if they are on inotrops. Because what you consider is कि भाई heart का function ठीक है, but the patient is on inotrop support, he is on sepsis, he is having hypoxia, he is having acidosis. लेकिन जब मैं अपने patient को ECMO पे लगाऊंगी तो जैसे ही oxygenation improve करेगा, जैसे ही acidosis improve करेगी, तो indirectly जो भी poor oxygenation या acidosis की वजह से जो heart का impact है, हार्ट पे इम्पैक्ट हो रहा है, वो रिवर्स हो जाएगा, एंड माय पेशेंट विल बी वीन्ड ऑफ आइनोट्रोप्स एंड the patient is going to improve. So if there is a low inotrop support, then only you need VV ECMO. All right. But remember that again, because of flow issues, अगर severely predominantly distributed septic shock है, vasodilated state पड़ी है, then probably in such patients putting a patient on ECMO is not a good idea. Already I think somebody repeated that slide कि क्या contraindication, ये सब चीजें इसलिए I am repeating because before jumping to initiate the ECMO, you have to revisit the table, you have to revisit your indications, your contraindications. So ECMO can be bridged to anything, but it cannot be a bridge to nowhere. So if there is no anticipated recovery of organ, if there is no plan for viable decannulation and the patient is not a candidate for transplant, please do not put the patient for ECMO. So ये अभिमन्यु का चक्रव्यूह है, इसमें घुस तो जाओगे, लेकिन अगर आपके पास exit plan नहीं है, तो then you will be landing yourself in a soup. So always ask कि जब मैं ECMO पे डालने जा रही हूँ, क्या मैं इसको मेरे पास कोई प्लान है निकालने का? अगर मेरे पास exit strategy नहीं है, तो don't put the patient on ECMO. Now we will come to we have already, Karan already talked about basic things about what a cannula, a venous cannula or a drainage cannula or a return cannula looks like. I am going to talk about steps of cannulation. Now remember, जैसे कि जब patient को ventilator पे डालते हैं, तो अगर अच्छे से endotracheal tube नहीं पड़ी है, गलत साइज की ट्यूब डाल दी, छोटी साइज की ट्यूब डाल दी, लीक हो रहा है, तो योर नॉलेज ऑफ एडवांस मोड्स ऑफ वेंटिलेशन इज रियली नॉट गोइंग टू हेल्प यू. तो अच्छा इंट्यूबेशन जरूरी है. उसी तरीके से अच्छे ECMO रन के लिए अच्छा कैनुला डालना जरूरी है. एंड यू हैव टू रिमेंबर every time Karan and Atiharsh, they have been talking about getting a good flow. So proper technique of insertion, proper size and proper placement is very important to get a good flow. If there is a good flow, you will have a successful ECMO. So first step is very important. The idea is to get the maximum possible flow by putting the maximum caliber of cannula, and also to minimize damage caused by turbulence. So कई तरह सिंगल ल्यूमन कैनुला होती है या सिंगल साइट इंसर्शन होता है जिसमें कि डुअल ल्यूमन कैनुला होती है, बट मोस्ट वी आर हियर टुडे टू टॉक अबाउट टू साइड्स कैनुलेशन. उसमें क्या होगा, एक कैनुला नहीं है, दो सेपरेट कैनुला होगी. यू विल नीड वन कैनुला फॉर ड्रेनिंग आउट द ब्लड. दैट ब्लड विल देन पास थ्रू द pump, then that pump will propel so pump is the artificial heart, and that pump is going to propel the blood towards the artificial lung. That artificial lung is the oxygenator, and then get heated and then return via the arterial cannula back to the patient's circulation. Now this return or arterial cannula is always called arterial, भले ही वो वीवी एक्मो हो या वीए एक्मो हो. Why? Because post the oxygenator, the blood, it will be oxygenated blood running in the return cannula. So it is always called arterial cannula, whether it is going back into the vein or the artery, right? Now, peripheral ECMO cannulation. There are different kinds of cannulation. The ones which are the one which is being done by CTVS surgeon, open cannulation during bypass surgeries, semi-open. But we are here to talk about percutaneous peripheral cannulation. So for VA ECMO, सबसे common cannulation जो हम adults में करते हैं वो कौन सा है? Femoral vein is the drainage or the access cannula, and femoral artery, either of the same side or of the other limb, is the return. So what does that mean, femoral vein? इसका मतलब cannula, is the blood going to be drained from the femoral vein? Yes or no? No. So femoral vein is not the reservoir for drain. हमें सबसे बड़ा reservoir चाहिए. सबसे reservoir क्या है? IVC. So what जब हम फेम बोलते हैं, फेम ECMO, है ना, इसका मतलब ये नहीं है कि वेन से हम ब्लड ड्रॉ करते हैं. वी आर जस्ट इंडिकेटिंग दैट femoral vein is the entry point. It is the puncture site. So I am going to cannulate my vein. I am going to cannulate my IVC all the way up to the junction between the IVC and the RA. है ना? That is going to lie in which portion of the IVC? तो इतनी लंबी होती है तो कहीं भी cannulate कर देंगे नहीं. We have to place the tip of the cannula at the intrahepatic portion of the IVC. Do we remember the anatomy? How the IVC drains into the RA, and just before it is draining, it also receives blood from the hepatic vein, right? So we have to take our cannula, the tip of the cannula, all the way up to the junction of the IVC and the RA, which is obviously intrahepatic and it is also supradiaphragmatic. So this is all important because this जब हम एक्सरे में और अल्ट्रासाउंड में देखेंगे तो हमें पता चलेगा कि हम कहाँ ले जा रहे हैं. Femoral vein is only the entry point, right? Why do we need it? Why do we need it to be in the intrahepatic portion? इतनी बड़ी IVC है, कहीं भी हो जाए. Why? Because vein is a collapsible entity. जरा सा भी फ्लो, क्योंकि हमको क्या चाहिए? हमें एक्सेस चाहिए. हम एक्सेस कैसे लेते हैं? पंप के थ्रू. पंप क्या है? एक क्या क्रिएट करता है? एक नेगेटिव साइड, लाइक अ मोटर पंप, टुल्लू पंप, जैसे पानी खींचने के लिए. तो जब अगर मोटर की स्पीड बढ़ेगी, so what will happen? The pump will become, the suction pressure will become more negative. तो क्या होगा? Pump is going to collapse. That is going to cause damage, turbulence, even it can cause air sucking in, and also to the least, it will not give you flow. So आपको अपना कैनुला ऐसे पोर्शन में डालना है जो कि नॉन कोलैप्सिबल हो relatively. तो relatively नॉन कोलैप्सिबल पोर्शन तो वो होगा ना जो within the liver parenchyma है. So just remember that. And femoral artery return कहाँ होगी? अभी Dr. Rati told. Yes. So anywhere below the bifurcation of the aorta per se. ठीक है? Then in children, what has happened कि femoral artery इतनी अच्छी develop नहीं हो पाती है. So sometimes if the child is more than 10 kg, it may be difficult to cannulate the femoral artery. So in children, and neonates, what we do, in pediatric younger children, we take the return to the axillary artery or the carotid artery, right? And बहुत छोटे बच्चों में, neonates में, तो then even the femoral vein is not developed. Then you have to take the configuration as IJV to axillary artery. VV ECMO में common route है. What is the commonest route that we use? We use take access from femoral vein and return to the IJV. Actually, what we do most commonly is take return to the IJV. So IJV में कहाँ होगा? Again, where is the tip of the return cannula or the arterial cannula going to lie? It is going to lie at the junction of the SVC and the RA. बट फिर क्या हुआ, कोविड टाइम आ गया तो सबको शुरू में बहुत डरने लगा कि हम तो उसके मुंह के पास ही नहीं जाना पेशेंट के. सो व्हाट हैपेंड, femoral vein access and femoral vein return also became very popular. But conventionally सबसे ज्यादा अगर आप ease पूछो तो femoral vein and internal jugular vein cannulation में होता है. Now, having a look at this, can you identify which one is the return cannula, which one is the drainage cannula? So obviously one is the color कि blue है तो drainage है, लेकिन look at the long length. क्यों? Why is it longer? It is longer because puncture point तो femoral vein है, but it is going to go all the way. What is this landmark? Yeah, but what is the surface landmark? Ziffy-Sternum and return cannula is shorter. So just remember कि अगर पहचानने में दिक्कत हो रही हो तो the access cannula या drainage cannula will always be very very long. And some cannula characteristic, ये सबको Poiseuille's physics का formula याद होगा कि the flow depends on the fourth power of radius. इसीलिए बार बार ये बताया जा रहा है that you have to take the maximum caliber of the access cannula which can be accommodated inside the vein. Arterial में it is forgiving. You can make some errors with judgment, but if you need a good access, you have to put the maximum allowable flow cannula. And it is both the cannulas, they are wire reinforced, polyurethane, made up of polyurethane, biocompatible, and they have side holes. And the drainage cannula, because it needs to get a good drainage, there will be multiple side holes. All right. And the return cannula, it is shorter. It will have two holes. One will be the main hole and the other will be another side hole. So that if one is blocked, then the other doesn't. So ये भी difference है. जो return cannula है, उसमें 2 holes होते हैं. Drainage cannula में multi-stage cannulas होंगी. You will have at least 10 to 15 holes. All right. Then as Karan told कि हम सारी जो कंपनीज होती हैं, चाहे वो बायोमेडिकस की हो या मैकी की हो, वो अपने अपने कैनुला के लिए वेट बेस्ड रिकमेंडेशन देती हैं कि कितने वेट में कितना कैनुला हमको ड्रेनेज डालना है और कितना कैनुला हमको, कौन से कैलिबर का कैनुला हमें डालना है आर्टीरियल कैनुला. बट फ्रॉम माय ओन एक्सपीरियंस and not so pleasant experiences, I can tell you that please never blindly go by these recommendations, because what really happens is कि जब हम Indian population में देखते हैं, every patient is different. Just by looking at the weight आप ये नहीं decide कर सकते कि इस size पे ये cannula लगेगा. We have landed up in soup. So there was this patient of sulfose poisoning. We decided to put an ECMO on her. We cannulated the vein. Vein is roomy. Vein is large, vein is going to distend, but that patient's arterial cannula, we just could not cannulate in time. And what was the reason? We went by the weight-based strategy and we also did the ultrasound, but still we were confused कि इतना जब हम ultrasound किया तो हमें लगा इतना छोटा caliber की return cannula कैसे जा सकती है. But what actually was there, that patient had severe atherosclerosis and the femoral artery was very, very narrow in caliber, and we had multiple failed cannulation attempts and we wasted a lot of time in that, and ultimately we were not able to cannulate the patient because we did not have that size of the cannula available. All right. So always, as current, so I'm also going to tell you subsequently how to calculate the diameter, but please don't go by weight based recommendations alone. ये simple circuit है, इसमें क्या है? You already everybody understand this, that blood is being drained from the inferior vena cava through a cannula which has been inserted through the femoral vein. फिर ये blood circulate होकर जा रहा है पंप में, पंप प्रोपेल कर रहा है इस ब्लड को ऑक्सीजनेटर में, एंड फिर ऑक्सीजनेटर से ये वापस जा रहा है आईजेवी में. एंड दिस इज द व्हिच कॉन्फ़िगरेशन इज दिस? वीए. बट वीए में क्या? फेमोरो. ऑलराइट. एंड व्हाट इज दिस एक्सेस एरो दैट यू कैन सी? Is this working? So what is this? Anybody?
For the perfusion of the lymph.
Yes. क्यों? क्योंकि जब आपका ब्लड जा रहा है तो ये नेचुरल बॉडी की जो नेचुरल दिशा है ब्लड फ्लो करने की, उस दिशा में नहीं है. This is a retrograde flow. So it is going to go land up somewhere in the aorta, descending aorta. That blood is going to land up in the aorta, but this limb will have कॉम्प्रोमाइज परफ्यूजन. तो क्या करते हैं, जब हम इस लिम्ब को कैनुलेट करते हैं, आर्टेरियल कैनुला डालते हैं, तो साथ में एक in the direction opposite to putting the first cannula, we also put a guide wire, and then we just put the pacing sheet, 7 French sheet, उससे cannulate कर देते हैं. और once an ECMO has started, what we do is we connect this returning blood through this distal perfusion cannula, and so that this part of this entire limb can also be perfused. All right. So it will draw blood around. So this is the circuit of VV and VA ECMO, and then the prerequisite for cannulation. So cannulation is not you have to properly take written informed consent. Patients के relatives की, because they are I don't know, yours is a government institute, but at our place a lot of money is at stake, a lot of reputation is at stake, and their expectations are also at stake. So you have to, जो अभी सब बताया कि it is not a treatment modality, it only provides rest. मरीज तो तभी ठीक होगा जब उसकी अपनी inherent problems ठीक होंगी. So you have to tell them that what things day wise क्या क्या expectation हो सकती हैं, क्या complications हो सकते हैं, how you are going to take care of them. है ना? Never overestimate the outcome of the ECMO. ठीक है? You need to have n number of sterile sheets, बड़े बड़े drapes you need. So please don't compromise on sterility, because there are going to be long cannulas, there are going to be long guide wires, and choose appropriate size cannula. है ना? Not just from the weight based chart, but as Karan had explained, you have to do the ultrasound and measure the diameter of the femoral vein as well as the femoral artery, or whatever the diameter. Suppose the diameter is 7 mm. So what is the French of the cannula that you are supposed to use? 7 3s are 21. And if it is return is, let's say, 4 mm or 5 mm, then you have to use 15. So what happened in our patient is that this patient's artery was really, really shiny, there was dense calcification, and the caliber was very, very narrow. Hence, we could not find the right cannula for the patient. The patient needed, let's say, 12 or 15 French cannula. We did not have it at time. और अगर हम उसके हिसाब से जाते तो cannulation हमारा 19 French पे हो जाना है. But we were not able to negotiate a 19 French cannula. So now we have learned our lesson. We never do cannulation without proper assessment of the caliber. Then you need series of dilator sets. So obviously you feel it is easy कि percutaneous cannulation तो हमने कर दिया, but putting a guide wire through a femoral vein is a different thing, but putting a large caliber vein is another game ball. So वो बड़ी कैनुला डालने से पहले you need to have multiple dilators or you do serial dilatation, and then you need long guide wires. जो femoral vein में guide wire या drainage femoral venous cannulation जो IGV में जाता है, उसका guide wire का length approximately कितनी सेंटीमीटर की चाहिए? Any idea? 150 centimeter. And obviously, if you are putting the return back to vein, femoral vein, or you're going to put into an IGV, you will need a relatively smaller length of the diameter, smaller length of the guide wire. Usually, जब हम femoro IJV, यानी कि femoral vein to IJV veno-venous करते हैं, तो we take 150 centimeter length का guide wire for drainage and around 75 centimeter for return. But remind you, ऐसा नहीं कि कोई भी guide wire चला जाएगा. You need that guide wire should also have a specific characteristic. It needs to be an extra stiff guide wire. So what guide wire we are using now is specifically from a specific company, Amplat's point. जो CTVS वाले होंगे उनको ये पता होगा. You need Amplat's 0.38 mm. Extra stiff guide wire. Why do you need an extra stiff guide wire? Because सिर्फ guide wire long है उससे काम नहीं चलेगा. You need to have the strength of the guide wire that is going to hold all these cannulas, because dilate भी हो गया. उसके बाद when you are putting the cannula, if you are not using an extra stiff guide wire, then that cannula, that guide wire is going to kink. तो आपको सब हो जाएगा. आपने कहा कि मैंने सारे dilators भी. See, I am only telling all these situations because I have faced these. So once we did not have a proper guide wire, हमने सोचा चलो interventional radiology से मंगा लेते हैं. I asked them, do you have a 150 centimeter guide wire? They said, yes, we have. I thought it is stiff. We decided to put it. Everything done. We just could not negotiate the return drainage cannula. So we had to remove it out. We had to find an extra stiff guide wire somewhere in the inventory, and then only we could do the cannulation in the second attempt. So you need a specific 0.38 mm Amplat's extra stiff guide wire. Then और क्या चाहिए? Pre-primed circuit चाहिए. Then you need the circuit. The circuit will generally be, ऐसा नहीं है कि cannulation कर दिया फिर याद आया कि मैंने circuit को prime किया है, तो then it's going to waste a lot of time. So you should keep your pre-primed circuit ready. What is priming of the circuit? Pardon? Priming of the circuit is कि हमको there should be no air in the circuit. So what is priming? Priming is basically de-airing of the circuit with around, let's say, 750 to 1 liter of replacement fluid. Either it can be ringer lactate or any fancy liquid you want to replace it with, or बच्चों में या जिनका hemoglobin कम है, you need to do the priming with blood. And depending कि patient कैसा है, suppose उसको anemic है, blood loss पहले हो सकता है, then you need to replace priming. You have to do patient specific priming. So आपका क्या है? ECMO circuit is an extra corporeal circuit. तो कोई भी foreign substance होगा तो blood अगर उससे contact करेगा तो क्या trigger होगा? क्या trigger होगा? Complement activation and yes, coagulation. So there will be intense thrombosis, and thrombosis is bad for the circuit, not just for the patient, for the circuit. तो अगर आपका पहले से प्री कोटेड सर्किट नहीं है तो वो प्राइमिंग के लिए सिर्फ फ्लूइड नहीं करना है, उसमें कुछ एडिटिव्स भी डालने हैं, एल्बुमिन भी डालना है, एफएफपी भी डालना है. You may have to add certain calcium also. All these things, I think we have workstations there, we can discuss all this thing. So basically पहले से, am I going too slow? Not because I'm sorry I may take long. क्योंकि अच्छा सर, क्योंकि मुझे लग रहा है जिस गति से मैं समझा रही हूँ, it may take another 10 minutes. So I hope you don't have any problem with that. है ना? कभी भी मुझे लगे बहुत धीमे है तो प्लीज मुझे रोक देना. All right. So pre-prime circuit, because see, when I am teaching you, I am not just talking to you. My own stored information is running in my mind. So I am learned so much from my mistakes. And every time when I tell, and I have seen these situations कि cannula डालने चले और तभी किसी को याद आया, अरे circuit prime नहीं किया. These are dangerous. These gives hard. And when जब कोई कहे तो circuit तो that is, I remember what I said to that person. That is why that person will never forget. I will also never forget. And you need heparin, surgical blade obviously, and you need a bedside ultrasound. बहुत जरूरी है while putting ECMO. ये तो बता ही दिया था. अब cannulation steps क्या है? Puncture. पंक्चर के बाद क्या करना है? आई हैड एन एक्सीलेंट वीडियो बट आई समहाउ आई कुड नॉट पुट इट हियर. एनीवेज, सो यू हैव टू डू अ पंक्चर. जैसे सेल्डिंगर तकनीक, पेन ड्रेप कर दिया. उसके बाद क्या किया? फिमोरल, लेट्स से कि हमें फिमोरल वेन कैनुलेट करनी है, तो हम क्या करेंगे? अपना इंट्रोड्यूसर नीडल डालेंगे. उस इंट्रोड्यूसर नीडल के थ्रू कौन सा गाइड वायर डालेंगे? पढ़ो क्या लिखा है, प्लीज ये कभी नहीं भूलना. एक्स्ट्रा स्टिफ 0.38 mm गाइड वायर, वो भी कितना लंबा? 150 सेंटीमीटर, अगर फिमोरल वेन कैनुलेट करनी है तो. ठीक है, फिमोरल वेन कैनुलेट कर दी. उसके बाद सपोज आई एम गोइंग टू डू अ वीवी एक्मो, देन आई विल कैनुलेट द आईजेवी. तो वो कितने सेंटीमीटर के गाइड वायर से? 50 सेंटीमीटर एक्स्ट्रा सिर्फ गाइड वायर यहाँ का डाल के छोड़ दिया. जनरली वी गिव स्मॉल डोज ऑफ हेपरिन, बिकॉज जब भी कोई आप फॉरेन चीज, आपने कैनुला गाइड वायर डाला, इवन दैट कैन कॉज क्लॉटिंग. तो आप एक स्मॉलर डोज 1000 यूनिट ऑफ हेपरिन वी एक्चुअली give to the patient before passing the guide wires. So I have cannulated the femoral vein and then I have cannulated the IJV for veno-venous ECMO. If I am going to do a VA cannulation, तब क्या करना है? femoral vein cannulate करने के बाद femoral artery cannulate करनी है. उसका guide wire shorter होगा, doesn't need to go all the way up. But if I'm अगर VA ECMO कर रहे हैं तो I need to pass an extra guide wire. So अगर femoral artery में मैंने guide wire डाला, उसके बाद मुझे चिंता है पेशेंट के पैर की, तो मैं क्या करूंगी? जहां पे मैंने femoral artery cannulation किया है और guide wire उसके just let's say 1 centimeter or 2 centimeter नीचे I am going to put another guide wire, शीट, पेसिंग शीट का गाइड वायर, सेंट्रल लाइन का गाइड वायर. लेकिन उसका डायरेक्शन क्या होगा? इस डायरेक्शन में होगा, नीचे डायरेक्शन में. ठीक है, सो नाउ आई हैव 3 गाइड वायर्स. नाउ आई एम गोइंग टू गिव ऑल माय डोज ऑफ हेपरिन. सो हमारी जनरली 50 to 75 यूनिट्स पर केजी. सो बोलस है तो आई विल गिव अराउंड 1000 I've already given. I'll give another 4000. All right, total 5000 हो गया. उसके बाद what I do is I start dilating this. So serial dilator set के through I'm going to dilate the femoral vein and the femoral artery, and then I am going to insert the appropriate size cannula up to the desired length. So one thing during insertion that you have to remember is कि don't treat it as a central line insertion. तो bend नहीं होना है कहीं भी. You need an assistant. So once आप थोड़ा थोड़ा insert कर रहे हो, please don't do screwing action. लोग क्या करते हैं कि स्क्रूइंग एक्शन करने लगते हैं. डोंट डू, बिकॉज जितना भी स्मूथ एक्शन नहीं होगा, स्क्रूइंग होगा, आप क्या करोगे? यू आर गोइंग टू कॉज टीयर इन द वेसल्स. जब टीयर वेसल कराओगे तो जितना ज्यादा टीयरिंग होती है तो वो सरफेस कैसा होता है? रफ हो जाता है. रफ सरफेस किस चीज को न्योता देता है? thrombosis को, clots formation को, which is bad for the ECMO circuit. So your motion should be smooth like this, not like this. And if you feel that you're not able to negotiate, you have to give a small skin nick to facilitate negotiation. ठीक है? And you have to insert cannula up to the desired length. What is the desired length? Desired length उसको जाना है. IVC में intrahepatic, how do you measure? You have to measure from here, from the notch. और उसमें गार्ड लगा होता है. You can pre-mark that guard. So you have to, generally for a well-built adult male, we have to insert around 45 to 50. All right, am I wrong, Atiharsh?
No,
40, 45, right. And here, so it is like central only. कहाँ जाएगा? जंक्शन में. तो अगेन यू, जैसे कि आप सेंट्रल लाइन के लिए मेजर करते हो, वैसे ही आप डिस्टेंस मेजर करके अगेन एक मार्कर लगाओ, तो उस मार्कर तक उसको खींच के फिक्स कर लो. ठीक है, सो व्हाट डू यू डू? यू देन पास, सारे डायलेटर्स पास हो जाते हैं. आई डोंट हैव द कैनुला हियर, अदरवाइज आई वुड हैव शोन वेरी ब्यूटीफुली. जो कैनुला होती है उसमें गाइड वायर होता है. ठीक है, उसका भी एक नॉट अ गाइड वायर, डायलेटर होता है. तो वो डायलेटर ऐसा होता है, उसके टिप से आगे होता है ना. तो डायलेटर और टिप के, कैनुलर टिप के बीच में एक टर्बुलेंट सरफेस आता है. सब कभी कभी वहां अटक जाते हैं, बहुत फोर्स लगाना पड़ता है ना. तो फोर्स नहीं लगाओ. अगेन यू विल नीड अ निक टू फैसिलिटेट मूवमेंट ऑफ योर कैनुला. ठीक है, अंडरस्टैंडिंग दिस. सो योर इंसर्शन एट ऑल टाइम पॉइंट्स शुड बी वेरी वेरी स्मूथ. ऑल राइट, एंड देन फिमोरल वेन में डाल दिया, फिर फिमोरल आर्टरी में, फिमोरल वेन में 45 डाल दिया सेंटीमीटर तक, फिमोरल आर्टरी में सॉरी आईजेवी विनोविनस कर रहे थे ना हम, आईजेवी में हमने डाल दिया डिजायर्ड लेंथ तक रिटर्न कैनुला, और अगर हमारा वीए एक्मो है तो फिमोरल वेन में डाला, फिर फिमोरल आर्टरी में डाला, और साथ में पेसिंग शीट 7.5 या 7 फ्रेंच की शीट हमने डाल दी डिस्टल परफ्यूजन वाली गाइड वायर पे. बस all this is done and then we confirm location. So how do we confirm location? एक्सरे से करना है. सबसे पहले हम क्या करेंगे, अल्ट्रासाउंड से देखेंगे. तो हमेशा ये पार्ट कहीं भी ECMO में you virtually need to pain drape the entire patient. So what you do, जब आप गाइड वायर डालते हो, you can always do an echo here and look कि गाइड वायर आपका कहाँ है ना. Similarly, फिर जब आप कैनुला डालोगे तो गाइड वायर निकाल लोगे, then again you through the echo you can see that your tip of the cannula is at the junction of the RA and the IVC. Are you able to appreciate that? है ना? It is at the, this is the liver, this is the intrahepatic portion of IVC, this is the hepatic vein, and your cannular tip is lying here. All right, and same you can confirm by putting a color also. Doppler करके भी color कर डाल के भी हम देख सकते हैं, और Doppler भी कर सकते हैं. Then कनेक्ट द कैनुला. अब क्या हो गया कि जब कैनुला डाल दी तो दोनों तरफ क्लैंप लग, जैसे ही कैनुला निकालोगे और उसका गाइड वायर निकालोगे, देयर इज गोइंग टू बी गश ऑफ द ब्लड, सो यू हैव टू इमीडिएटली क्लैंप इट. बट रिमेंबर वन थिंग, द कैनुला हैज अ वायर रीइंफोर्स पोर्शन. जब कैनुला हम वर्क स्टेशन पे देखेंगे तो वी विल सी कि कैनुला में एक वायर रीइंफोर्स पार्ट होता है. नेवर पुट योर क्लैंप ऑन द wire part, always put it distally, otherwise your cannula will be damaged. Cannula भी पड़ गई, so you have to be mindful at every step. आपका your alertness level should be 100, है ना. कि अगर आपने कैनुला क्लैंप अच्छा कैनुलेशन कर दिया लेकिन क्लैंप लगा दिया वायर रिफॉर्मेशन में, कैनुला इज डैमेज्ड. ठीक है. And always use non-crushing clamps. Don't think that you can put any clamp. There are specialized surgical clamps called the non-crushing clamp. अगर आप मैकी के सर्किट यूज करते हो, they also give you that blue kind of clamps, but they are not really good enough to always. तो ठीक है, काम चल जाएगा, but you need to put double clamps. इसलिए always use non-crushing clamps. Always keep them in the inventory. Then what you do is you connect the cannula with the circuit, but only after checking the ACT. तो once जब आपने सब cannula डाल दी, सब कुछ है, what you have to do is you have to do a final ACT, activated clotting time. You've already given heparin, all right. So how much ACT you need? How much? So what is the range is 160 to 200 or 220. So in veno-venous ECMO you will be running the ECMO on a higher flow. So you can keep, जितना ज्यादा flow high होगा मतलब ब्लड बहुत जल्दी से पास करेगा, तो उसकी clotting tendency कम होगी क्योंकि उसका stagnation कम होगा. तो you can keep lower ACT. So you can keep a ACT of around 160 to 180. All right. But if you are putting the patient on VA ECMO, in VA ECMO, you do not need to pump the entire cardiac, I'll tell you later, you do not need to pump the entire cardiac output, so you can put the cannula, चूंकि आपका ब्लड जो है वो स्लोअर फ्लो पे, कम स्पीड पे मूव करता है, इसलिए आपको हायर एसीटी चाहिए. सो फॉर VA ECMO you need higher ACT of around 180 to 200, right? And then जब तक आपने ACT, अगर आपका ACT कम है तो क्या करोगे? तुरंत give more bolus of heparin, है ना, give extra heparin, give 2500 heparin and then again do ACT. कभी कभी क्या होता है, हमने 5000 heparin दे दिया, हम कैनुलेशन करने में हम सोच रहे हैं 30 मिनट्स में करेंगे, हमें ज्यादा टाइम लग गया, हमें 1 घंटा लग गया और लग जाता है इतना टाइम, तो क्या हुआ, हेपरिन का तो काम कम हो जाएगा. तो इसलिए ऑलवेज बिफोर फाइनल कनेक्शन यू ऑलवेज हैव टू डू ACT. और अगर कम है तो हेपरिन दो. एंड केयर नॉट टू लेट एयर एंटर इनटू द सर्किट. जब आप कनेक्शन कर रहे हो, क्लैंप्स लग रहे हो, क्लैंप कनेक्ट कर रहे हो, देयर इज अ टेक्निक विच वी शुड लर्न इन द वर्कशॉप कि उसको कैसे एयर नहीं आने देनी है. बिकॉज अगर एयर आ गई तो फिर अगेन इट्स लाइक हैविंग अ एम्बोलिज्म, है ना. सो देन that will be a very deathly thing, so you have to avoid air. And once you avoid the air, then what do you do is slowly increase rpm to 1200. धीरे धीरे 1200 का आपने rpm बढ़ाया. क्या बढ़ाया? जो पंप स्पीड होती है, पंप स्पीड है वो कितने आरपीएम पे की? रफली 1200 पे. अगर आपका छोटा it actually depends upon the machines, but we are using Mackie, so we increase the pump speed to 1200. जब 1200 पे पंप, अभी अपने क्लैम्प्स नहीं हटाए हैं, माइंड यू, क्लैम्प्स हमने सब लगा के रखे हैं. हेलो, क्लैम्प्स हमने सब लगा के रखे हैं. हम क्या करेंगे? पहले आरपीएम बढ़ाएंगे. आरपीएम क्यों हम बढ़ाते हैं क्लैंप हटाने से पहले? बिकॉज व्हाट करण सेड इज दैट वी आर यूजिंग व्हाट काइंड ऑफ पंप्स? वी आर यूजिंग सेंट्रीफ्यूगल पंप्स. तो अगर सेंट्रीफ्यूगल पंप को दे आर प्रेशर एंड आफ्टर लोड डिपेंडेंट, दे आर नॉट इंडिपेंडेंट. दे जैसे बताया ना, दे आर नॉट लाइक दोज आपका रोलर और रेसवे पंप्स की माइंडलेसली वो ब्लो करते चले जाएंगे, वो नहीं करेंगे. तो क्या होगा? इफ यू डू रिमूव द क्लैम्प्स एंड यू डू नॉट prior to increasing the pump speed to 1200, तो क्या होगा? बैकफ्लो आ जाएगा सारा. So you do not want that बैकफ्लो. तो आपको सबसे पहले क्या करना है? क्लैम्प्स नहीं हटाने हैं, सर्किट कनेक्ट करना है, पहले आरपीएम को 1200 करना है. फिर क्या चीज रिमूव करनी है? पहले रिमूव करना है वीनस साइड का क्लैम्प, है ना, वीनस साइड का क्लैम्प. और उसके बाद फिर क्या करना है? Then you have to remove the arterial side of the clamp. So please remember, in centrifugal pumps in ECMO, whenever you have to go to the, अगर पेशेंट को ECMO पे लेना है कभी भी किसी भी पॉइंट पे, तो क्या करना है? सबसे पहले स्पीड बढ़ानी है, फिर वीनस क्लैम्प को रिलीज करना है, फिर आर्टीरियल क्रैम्प को रिलीज करना है. और जब रिलीज हो गया तो तुरंत ब्लड सर्कुलेट करने लगेगा, बैकफ्लो नहीं आएगा. देन यू कैन स्लोली इंक्रीज द आरपीएम टू गेट द डिजायर्ड फ्लो. तो कितना फ्लो चाहिए? डिजायर्ड फ्लो की तो बात कर ली, 12 से अब बढ़ाना है. अब कितना बढ़ाना है? डिजायर्ड फ्लो में कितना चाहिए? मैंने बोला था कि वीवी एक्मो में तो पूरा ही कार्डियक आउटपुट सर्कुलेट होगा ना, हार्ट के थ्रू लंग में जाएगा, तो यू नीड हायर फ्लोज. सो यू नीड फ्लोज ऑफ अराउंड 120 ml per kg of the body weight. That comes actually to the entire cardiac output. So अगर हम अडल्ट की बात करें तो यूजुअली वी नीड अ फ्लो ऑफ अराउंड 4.5, 5, 5.5, है ना. बट VECMO में वी आर नॉट टेकिंग द पेशेंट ऑन टोटल बाईपास. अगर टोटल बाईपास का CTVS में सर्जरी कर रहे हो तो टोटल बाईपास चाहिए, तो उसमें भी हायर फ्लो चाहिए. लेकिन यहाँ हम क्या कर रहे हैं? पार्शियल बाईपास पे करते हैं, क्योंकि दो तरीके के सर्कुलेशन VECMO में रन करते हैं. एक तो हार्ट पंप कर रहा है वो सर्कुलेशन जो कि थोड़ा कॉम्प्रोमाइज्ड है, प्लस एक जो आप सर्कुलेशन दे रहे हो जिसमें ब्लड इज नेवर गोइंग टू गो थ्रू द हार्ट. सो यू कीप द पेशेंट ऑन 80 और 90% बाईपास. तो इसलिए हमें VECMO में कितना फ्लो चाहिए? कम चाहिए. तो अगर 120 हम रख रहे हैं लेट्स से VECMO में, तो वी नीड अराउंड 80 to 100 in VECMO. दैट इज व्हाई वी नीड मोर हेपरिन इन VECMO, क्योंकि ब्लड इज गोइंग टू बी मोर स्लोली मूविंग. ऑलराइट. एंड बट ये ऐसा नहीं है कि तुरंत से हमें सारा फ्लो कर दिया तेज, हमको धीरे धीरे, बिकॉज फ्लो अगर हम पंप की स्पीड बढ़ाएंगे और फ्लो जनरेट करेंगे तो ब्लड निकलेगा. तो इफ वी वांट लेस टर्बुलेंस, इफ वी वांट एवरीथिंग टू बी हार्मोनियस, दैट इंक्रीज शुड बी ग्रेजुअली. सो यू हैव टू बिल्ड अप द फ्लो ग्रेजुअली. यू हैव टू titrate and then see the response. So 20 ml per kg every minute करके हमको desired उस पे ले जाना है. So usually जब हम VV ECMO पे डालते हैं कोई RDS का पेशेंट, तो usually we need a total flow of let's say 4.5 और 5 और 5.5. और VECMO अगर हम सेल्फॉस या किसी तरीके के पेशेंट में डालते हैं, समटाइम्स इवन 3.5 लीटर ऑफ फ्लो VECMO में काफी होता है. ठीक है. और ये तो रही कि खोलने की बात. किसी भी वजह से हमको लगे सर्किट में कोई प्रॉब्लम है और हमें उसको बंद करना है, तो हम बंद भी वैसे ही करें, उल्टे रिवर्स करेंगे. रिवर्स कैसे करेंगे? We put the arterial clamp first. आर्टीरियल क्लैम्प फर्स्ट करेंगे, जो भी स्पीड है उसको स्लो करके, आरपीएम की स्पीड को स्लो करके कितने पे ले जाएंगे, 1200 पे, और फिर हम वीनस क्लैम्प लगाएंगे, ठीक है, so that there is no back flow. So remember, whenever we are putting the patient, how we release the clamp, V and then A, all right. And when we are, for any reason we have to stop the immediately, कोई चीज हो गई और हमें part replace करना है, या something, air is going, yes, thrombus is happening or anything is happening, what we do is we go AV. So we clamp artery first, then bring down the pump speed, and then we clamp the vein. And when we troubleshoot the problem again, if we have to open the circuit, we open the vein, we increase the RPM to 1200, we open the venous clamp, then we open the arterial clamp. So this is looking at it, can we identify which one is the drainage cannula and which is the return cannula? Okay, and can you appreciate, so this is VV or VA ECMO? Huh? All right. Then Rati Prabha I think said कि दोनों return और drainage cannula के बीच में distance कितना होना चाहिए, 10 centimeter. But this distance is irrelevant in VA ECMO. This is only important for VV ECMO because it is going to be the in venous. तो अगर आपका यहाँ पे return है IJV में और वापस इधर आ रहा है तो distance कितना होना चाहिए, 10 centimeter. This we should be able to locate through ultrasound also, and हम X-ray कराएंगे तो X-ray में भी हमको मिलेगा, पर X-ray में 10 centimeter नहीं, X-ray में कितना मिलेगा, 15 centimeter का difference roughly. Why? Because X-ray में जो tip वाला portion होता है that is not X-ray radio sensitive. All right. Only thing is it should not be too close. अगर too close होगा तो जितना भी return हो रहा है वो वापस कहाँ जाएगा, return cannula में, access cannula में आ जाएगा, है ना. So क्या होगा, हाँ recirculation होने लगेगा, तो body तक तो पहुंचेगा नहीं, वो दोनों आपस में खेलते रहेंगे, ठीक है. Then double Lubin cannula, I have never seen it. पहले तो 4 size cannula आते थे, अब ज्यादा size cannula आने लगे हैं, but I have never seen it. I have never used it. I have never seen anybody who I know using it. So अब initiation के समय क्या क्या issues आ सकते हैं. पहला issue है कि कोई change of color ही नहीं आया. Change of color मतलब जब आप blood निकाला तो निकालने वाली limb में तो deoxygenated तो dark होना चाहिए. Return वाले में क्या हुआ, ब्राइट रेड, रिटर्न कैनुला में ब्राइट रेड होना चाहिए पोस्ट ऑक्सीजनेट, लेकिन आपने क्या देखा कि दोनों में कोई कलर चेंज नहीं है, या तो दोनों ब्राइट रेड है या दोनों डार्क हैं. दोनों ब्राइट रेड है तो क्या मतलब पेशेंट का तो दोनों ब्राइट रेड है, आप लेकिन पेशेंट डिसैचुरेट कर रहा है, ऐसा क्यों, रीसर्कुलेशन, राइट. जितना भी ऑक्सीजनेट किया था उसने ब्लड वापस ड्रेनेज कैनुला के थ्रू सर्किट में दोबारा, तो पेशेंट इज गोइंग टू डिटेरियोरेट. सो और अगर दोनों अगर डार्क रेड है तो ऑक्सीजनेटर खराब, अभी तो शुरू किया, ऑक्सीजनेटर क्यों खराब हो गया, ऐसे मत बोलो, यू कांट से दैट कि ऑक्सीजनेटर खराब हो गया, फिर आपने क्यों खराब ऑक्सीजनेटर लगाया, प्रोलॉन्ग कैसे, अभी तो व्हाट इज रिटन, व्हाट इज रॉन्ग कैनुलेशन, मतलब तो क्या हुआ, आप उससे क्या हुआ, आप वीए कर रहे थे, आपने वीवी कर दिया, वीवी में भी तो ऑक्सीजनेटर के थ्रू तो पास करेगा. बहुत सिंपल चीज, आपने ऑक्सीजनेटर को लंग तो माना, लेकिन उस लंग को ऑक्सीजन नहीं दी. आपकी जो वॉल माउंटेड सोर्स है ऑक्सीजनेटर, अपने ऑक्सीजनेटर में ऑक्सीजन भरी नहीं होती है, वो तो आप डालते हो ना, दिस इज अ वेरी कॉमन मिस्टेक. तो ऑक्सीजनेटर को कनेक्ट भी करना है वॉल माउंटेड, अगेन अ रियल लाइफ सिचुएशन, दैट इज व्हाई आई एम टेलिंग, है ना. तो दोनों डार्क रेड है तो भाई ये तो मालिक चेक करो ना सबसे पहले कि ऑक्सीजनेटर कनेक्ट किया था कि नहीं, ऐसा तो ना सैचुरेशन नहीं हो रहा, वेंटिलेटर कनेक्ट, भाई तो तुमने उसमें वेंटिलेटर में एयर सप्लाई पे लगा है, ऑक्सीजन सप्लाई पे लगा ही नहीं, तो क्या करो. सो जस्ट रिमेम्बर, ये दिस इज अ वेरी कॉमन प्रॉब्लम, सो ऑलवेज रिमेम्बर. देन अनस्टेबल ब्लड प्रेशर, अनस्टेबल ब्लड प्रेशर किस वजह से हो सकता है, आपने पेशेंट को एक्मो पे डाला, सर्कुलेशन लेना शुरू किया, सडनली पेशेंट का ब्लड प्रेशर क्रैश करने लगा, तमाम तरीके के अलार्म बजने लगे. व्हाई इज अनस्टेबल ब्लड प्रेशर, बिकॉज मे बी योर पेशेंट वाज नॉट वेल वॉल्यूम लोडेड फर्स्ट, आपने इतनी बड़ी कैनुला से फ्लो निकाल रहे हो, तो अनस्टेबल ब्लड प्रेशर के 2-3 कारण हो सकते हैं. एक तो पेशेंट वॉल्यूम डिप्लीटेड है, या आपका पेशेंट कहीं से ब्लीड कर रहा है, कैनुला के थ्रू कहीं से ब्लीड कर रहा है. दूसरा, आपका फ्लो बहुत ज्यादा है, आपने बहुत तेजी से सक किया, है ना. So always grow slowly. तो be mindful of these situations. Then unstable flow कि सब कुछ कर दिया पर flow अच्छा नहीं आ रहा. तो अनस्टेबल फ्लो का मतलब या तो कैनुला सही से प्लेस नहीं है, या कैनुला किंकिंग हो रही है, और पेशेंट नेगेटिव, जो क्योंकि पंप तो सक्शन कर रहा है ना, तो पंप सक्शन अलार्म दिए जा रहा है, नेगेटिव हुआ चला जा रहा है, लेकिन फ्लो नहीं आ रहा. तो ऐसे में क्या करोगे, फ्लो को थोड़ा कम करोगे, ठंडा दिमाग रखोगे और सोचोगे कि फ्लो करने के लिए हम इमीडिएटली क्या कर सकते हैं. तुरंत फ्लो बढ़ाने के लिए शरीर में कुछ डालोगे तभी तो फ्लो आएगा. सो इमीडिएटली गिव फ्लूइड. दिस हैज हैपेंड विद अस. वी वर पुटिंग, क्योंकि बच्चों का इतना आइडिया नहीं, बट वी वर कैनुलेटिंग. इट वाज अ लार्जर बेबी, सब 15 किलो का. सोचा कि चलो कर ले जाएंगे, तो वी पुट द पेशेंट ऑन एक्मो. एक्मो का सर्किट हमारा अडल्ट का था, बच्चा 15 किलो का था. तो जैसे ही उसने सक किया, इतने बड़े रिजर्वॉयर में ब्लड आ गया, पेशेंट स्टार्टेड डिटेरियोरेटिंग. सो व्हाट वी डिड, वी हैड नेवर थॉट कि ऐसा भी हो सकता है. लकीली वी हैड रिंगर लैक्टेट, वी पुश्ड रिंगर लैक्टेट एंड ब्लड वाज अवेलेबल. हमारे पास 1 पॉइंट ब्लड था, तुरंत हमने अवेलेबल किया था, वो हमने दे दिया. एंड उससे पहले हमने फ्लो को थोड़ा कम किया, क्योंकि टाइम, ये सब करने के लिए तो टाइम चाहिए ना. इमीडिएटली पेशेंट की डिमांड कम कर दो, फ्लो को थोड़ा कम किया. वी गेव फ्लूइड, वी गेव ब्लड ऑल विद इन टाइम फ्रेम ऑफ 5 मिनट्स एंड फ्लो, उसके सारे अलार्म बंद हो गए, अच्छा फ्लो आने लगा एंड वी वर एबल टू रन द सर्किट एंड अल्टीमेटली दिस पेशेंट गॉट सेव्ड. ठीक है. अनस्टेबल सैचुरेशन, आपने पेशेंट को एक्मो पे डाला, वीवी एक्मो पे डाला, आप तो सोच रहे थे कि पेशेंट का सैचुरेशन इंप्रूव हो जाएगा, बट डोंट वरी. अगर वीवी एक्मो में इवन योर, सो लॉन्ग एज द कलर ऑफ द टू लिम्स इज गुड, इफ द सैचुरेशन जो आपके बॉडी में आ रहा है 75 आ रहा है, 80 आ रहा है, इट डजंट मैटर, बिकॉज ultimately that blood which you are giving, oxygenated blood that you are giving through the heart, it will go to the RA, go to the RV, then it will go to the lungs now. But those lungs are damaged, they will take time to recover. So don't worry, so long as the circuit is working well and your hemodynamics is stable, don't worry. But VA ECMO में what you expect कि आपका तो तुरंत 100% हो जाना चाहिए, है ना. So again, if there is unstable saturation, look at the 2-3. अगर for 1-2-3 देखो कि 1-2-3 में कोई गड़बड़ तो नहीं है. Mostly these 3 are the problems: unstable flow, unstable blood pressure, unstable color. तो उसकी वजह से unstable saturation is possible. Then loss of pulsatile flow. This is only applicable in case of VA ECMO. तो VA ECMO में क्या होता है, हम ब्लड निकालते हैं, ब्लड doesn't go to the हार्ट. कहां जाता है ब्लड तो फिमोरल आर्टरी में नहीं, फिमोरल आर्टरी के थ्रू डिसेंडिंग पार्ट ऑफ द एओर्टा में जाता है, और उतने फ्लो से जाता है कि सब जगह पहुंच जाता है. वही फ्लो से वो पूरा रेट्रोगेट जाते हुए आपकी ब्रेकियोसेफेलिक आर्च को भी करेगा ट्रांसफ्यूज, ब्रेन को भी करेगा, सब कुछ करेगा, और हार्ट तो बहुत कम कॉन्ट्रैक्ट कर रहा होता है ना. सो इट इज गोइंग टू गो इन द रेट्रोगेट फैशन. तो अगर आप टोटल बाईपास पे डाल दोगे तो क्या होगा कि पूरा टोटल बाईपास पे डालने का मतलब द बॉडी इज डिपेंडेंट ऑन द रेट्रोगेट फ्लो ओनली, जैसा कि हम करते हैं जब हम बाईपास सर्जरी कर रहे होते हैं. बट हम जब पेशेंट को वीए एक्मो में लेते हैं, हमको टोटल बाईपास पे नहीं लग लेना है. टोटल बाईपास पे लेने पे क्या होगा, वी हैव टू एक्चुअली अलाउ फॉर सम कॉन्ट्रैक्टिलिटी. We have to go on, let's say 80-90% bypass. तो हमें थोड़ी क्या कहते हैं कॉन्ट्रैक्टिलिटी हार्ट की मेंटेन करके रखनी है, ताकि हार्ट अपना काम करता रहे. क्योंकि अगर हार्ट काम नहीं करेगा और हमने बहुत ज्यादा फ्लो लगा दिया, हमने उतना फ्लो लगा दिया जितना वीवी एक्मो में 120 बोला था ना, तो अगर आपने 5.5-6 लीटर का फ्लो लगा दिया वी एक्मो में, तो सारा रेट्रोगेट फ्लो होगा. और रेट्रोगेट फ्लो क्या करेगा, सो डू वी हैव अ मार्कर और एनीथिंग? नो. So what will happen is that, so this is the heart, this is the arch of aorta, और हार्ट को जो भी यहाँ पर होता है सब कुछ आफ्टर लोड होता है ना. तो अगर रिटर्न कैनुला यहाँ पर आकर कहीं है, अब अगर ये बहुत ज्यादा फ्लो हो जाएगा तो इतना ज्यादा हार्ट के लिए आफ्टर लोड हो जाएगा कि हार्ट की जो थोड़ी बहुत पंपिंग हो रही थी, आपका हार्ट वाज कॉम्प्रोमाइज्ड, बट स्टिल पेशेंट वाज नॉट डेड ना. 10%, 15% कुछ तो धड़क रहा था जी. बट अगर आपने यहाँ पर इतना ज्यादा रिटर्न फ्लो कर दिया, तो दिस हार्ट विल अगेन फेल इवन मोर, है ना. ये बिल्कुल स्टैसिस में चला जाएगा, पूरा स्टैसिस में चला जाएगा. तो क्या होगा, नहीं होगा, आपकी कॉर्नरी स्टनिंग हो जाएगी, हार्ट एकदम स्टॉप हो जाएगा, पेशेंट विल गो ऑन टोटल बाईपास, और जो आपने आर्टेरियल लाइन डाली थी वो फ्लैट लाइन देने लगेगी, या उसकी पल्सेबिलिटी बहुत कम हो जाएगी, पल्स प्रेशर विल बिकम लेस देन 10, so you don't want that, ऑलराइट। तो आपको अगर ऐसा होने लगे कि VAMO डालते समय ही आपका सब कुछ अच्छा है बट पल्स लाइन फ्लैट होने लगी, इसका मतलब अब हार्ट कार्डियक स्टनिंग में जा रहा है, तो इमीडिएटली व्हाट टू डू, लोग घबरा जाते हैं, लोग क्या करते हैं, ECMO की स्पीड बढ़ा देते हैं, आपको बढ़ाना नहीं, एक्चुअली कम करना है, ऑलराइट, सो दैट दिस हार्ट डज नॉट हैव टू compete with the flow। तो जब आप इसके फ्लो को थोड़ा कम करोगे तो इस पे जो बोझ है हार्ट पे कम पड़ेगा एंड देयर विल बी सम कॉन्ट्रैक्टिलिटी। नाउ यू मे से कि आई हैव पुट द पेशेंट ऑन ECMO, मध्यम के हार्ट हमें क्या फर्क पड़ता है, फर्क तो पड़ता है, बिकॉज़ इफ द हार्ट इज नॉट गोइंग टू कॉन्ट्रैक्ट, उसकी मायोकार्डियम इज गोइंग टू नेक्रोस, दैट इज गोइंग टू रिलीज पोटेशियम, मोर डैमेज टू द पेशेंट। ऑल्सो अगर हार्ट काम नहीं करेगा तो हार्ट के पीछे लंग पड़े, तो जो भी हार्ट में ब्लड होगा वो क्या होगा, एलवी स्टैसिस हो जाएगा, वहां क्लॉट बन जाएगा, क्लॉट इज अगेन डेंजरस, और क्या हो जाएगा, पल्मोनरी एडिमा भी हो सकता है, सो ऑल दीस थिंग्स आर कैटास्ट्रोफिक। तो प्लीज इफ यू से दैट आपका पेशेंट की पल्सेबिलिटी जा रही है ना, तो डोंट इंक्रीज दैट, अरे कि पेशेंट की पल्सेबिलिटी नहीं आ रही, चलो मैं फ्लो और बढ़ा दूं, पंप फ्लो नहीं, पंप फ्लो को आपको एक्चुअली कम करना है, सो यू डू नॉट वांट अ फ्लैट लाइन, यू वांट सम पल्सेबिलिटी, है ना। तो जैसे ही आप, ये तो आपने सबने सुना होगा कि जैसे ही VA ECMO में डालते हैं तो पल्सेबिलिटी कम हो जाती है, मैप नहीं चेंज होता, लेकिन सिस्टोलिक डायस्टोलिक हो जाता है, कम हो जाता है, डेफिनेटली एक्सेप्टेड, कम हो जाता है, लेकिन सिस्टोलिक डायस्टोलिक को बिल्कुल सेम नहीं करना है। सिस्टोलिक और डायस्टोलिक के बीच में कितना गैप रखना चाहिए, एटलीस्ट 10 का गैप तो आपको रखना ही है, टू मेंटेन सम, हार्ट को रेस्ट देना है, उसको मारना नहीं है, गेटिंग माय पॉइंट। One up monitoring. I hope nobody. Are you getting bored? Am I dragging too long? I don't know. You are saying, so I can continue. Rati Prabha, is there a problem? Okay. So now one needs to do the. आपने टॉपिक ही मुझे इतना लंबा दिया. You need to monitor everything. तो अभी ये नहीं कि ECMO खत्म हो गया तो अब काम खत्म हो गया, अब तो चलने लगा, पर भाई हर शिफ्ट में, हर 6 घंटे 8 घंटे की शिफ्ट में यही लंबा काम और बहुत ही दुखदाई और बहुत ही बोरिंग सा काम करना है, लेकिन ये बोरिंग ही रहे तब तक अच्छा है, अगर ये एक्साइटिंग बन गया इट्स नॉट गुड फॉर यू। सो एवरी टाइम यू नीड टू हैव अ सेपरेट ECMO चार्ट, और ये सारे पैरामीटर्स मॉनिटर करने हैं, सर्किट मॉनिटर करना है, सर्किट को विजुअली देखना है, पैरामीटर्स मॉनिटर करने हैं, पेशेंट को देखना है, उसको क्लिनिकली, बायोकेमिकली, रेडियोलॉजिकली, तमाम चीजें, और साथ में वेंटिलेटर को भी देखना है। ये बताना भूल गई, शायद आई मिस दैट पॉइंट कि वंस यू पुट द पेशेंट ऑन ECMO यू हैव टू, यू डोंट नीड द सेम वेंटिलेटर सेटिंग, क्योंकि अगर ECMO पे ECMO पे डाला और वेंटिलेटर की सेटिंग अभी भी वही है तो फिर क्या फायदा हुआ, है ना। तो उसको आपको ग्रेजुअली कम करना है ना, तभी तो वेंटिलेटर इंड्यूस लंग इंजरी मिनिमाइज होगी। तो ECMO में ग्रेजुअली कम करना है, VA ECMO में तो मतलब ही नहीं है, लंग से कोई अब मतलब ही नहीं रहा, तो उसको एकदम से भी कम कर सकते हैं। रेस्ट वेंटिलेटर सेटिंग मतलब एवरीथिंग 10, रेस्पिरेटरी रेट 10, पीप 10, एंड आपका जो, अगर आप PCV पे कर रहे हो तो जस्ट मेंटेन कि इतना ही टाइडल वॉल्यूम देना है कि उसका पीक इंस्पिरेटरी प्रेशर हमेशा 25 से कम हो, या वॉल्यूम कंट्रोल में डालना है तो इतना ही टाइडल वॉल्यूम देना है कि उसका प्लेटू प्रेशर 25 से कम हो, तो इवन 100-120 ml ऑफ टाइडल वॉल्यूम इज सफिशिएंट, गेटिंग माय पॉइंट, एंड FiO2 ऑफ 40%, रेस्ट ECMO विल टेक केयर। सर्किट में क्या करना है, जब भी इंस्पेक्शन करने जाओ एक अपने साथ टॉर्च लेकर आओ, और पूरा यहाँ से लेकर पेशेंट को एक्सपोज करके पूरा एंट्री पॉइंट से लेकर पंप, कैनुला साइट्स, पंप, ऑक्सीजनेटर, हीमोथर्म, ECMO कंसोल, और वापस यहाँ सब अच्छे से एग्जामिन करना है ना। क्या क्या देखना है, क्लॉट्स देखने हैं, कहीं क्लॉट्स तो नहीं इकट्ठा हो रहा, कहीं एयर तो नहीं आ रही, कोई लीक्स तो नहीं हो रहा, पता चले ब्लडी बाहर जा रहा है, किसी को पता ही नहीं है, कोई येलोइश कलर के फाइब्रिन डिपॉजिट, अगर ये सब हो रहा है, फाइब्रिन डिपॉजिट्स का मतलब क्लॉटिंग शुरू हो रही है, इसका मतलब ये नहीं कि क्लॉटिंग हो रही है तो तुरंत ही खत्म, बट यू हैव टू बी माइंडफुल ऑफ थिंग्स कि माय ECMO सर्किट में बी रनिंग इट्स लाइफ थ्रू इट्स लाइफ। देन ये देखना है कि कोई ट्रैक्शन हो, इतना लंबा सर्किट होता है, कहीं खिंच तो नहीं रहा है ना? अगर खिंच गया तो क्या होगा? एक्मो ही पुल आउट हो जाएगा। चेक गैस सप्लाई टू द ऑक्सीजनेटर, ये तो हमेशा ही माइंडफुल रखना है ना, कि कोई वो जोक सुना है ना कि वो एक हर सुबह 4 बजे उस बेड पे 4 बजे ही मौत होती थी, है ना? तो सब सोचते थे कि इस बेड में कुछ भूत लगा हुआ है, बट ऐसा नहीं था। वहां एक सफाई करने के लिए वार्ड बॉय आता था और वो डिस्कनेक्ट कर देता था। तो कहीं ऐसा आपके पेशेंट के साथ तो नहीं हो रहा कि जो उसका ऑक्सीजनेटर है उसकी गैस पाइप हट गई है? तो प्लीज, इट्स सिंपल, वी कैन लाफ टुडे, बट एट द पेशेंट साइड वी हैव टू बी वेरी माइंडफुल ऑफ दिस। ऑलराइट, देन एक टॉर्च लो। व्हाट इज दिस? दिस इज द ऑक्सीजनेटर। तो ऑक्सीजनेटर में देखो कि कहीं उसमें फाइब्रिन डिपॉजिट, एयर या कोई क्लॉट्स तो नहीं आ रहा है ना? क्लॉट आ रहा है इसका मतलब ये नहीं, इसका मतलब लंग में क्लॉट हो रहा है तो थ्रोम्बस बन रहा है। सो यू हैव टू बी माइंडफुल ऑफ दैट डजंट मीन दैट इमीडिएटली यू हैव टू चेंज द ऑक्सीजनेटर, बट यू हैव टू डू अदर थिंग्स आल्सो व्हिच आई एम गोइंग टू टेल लेटर। लेकिन अगर पंप में बड़ा क्लॉट, ये पंप हेड है ना, तो पंप में ऑक्सीजनेटर पंप में भी टॉर्च मार के देखो, लुक फॉर एनी, लिसन फॉर एनी अबनॉर्मल साउंड, कहीं उसकी बियरिंग तो नहीं टूट गई। वैसे तो आजकल बियरिंग लेस पंप्स भी आते हैं, बट अगर बियरिंग टूट गई तो क्या होगा? हीट जनरेट होगी, फ्रिक्शन होगा, तो क्या होगा? हिमोलिसिस होगा, क्लॉटिंग होगी। दीज ऑल थिंग्स आर प्रॉब्लमैटिक। ऑलराइट, अगर ये सारी प्रॉब्लम क्रिएट कर रही हैं तो इनको चेंज करना है, ट्रबल शूटिंग करनी है, वो मैं नहीं बताऊंगी, विद दैट राघवेंद्र इज गोइंग टू टेल, बट यू मस्ट नो कि हाउ यू हैव टू इंस्पेक्ट। देन अगेन ये क्या है? रिटर्न कैनुला फॉर अ वीए एक्मो। ऑलवेज लुक कि तुमने तो डिस्टल परफ्यूजन कैनुला डाला हुआ है, लेकिन वो डिस्टल कैनुला में अगर कोई क्लॉट अटक गया तो क्या होगा? You are happy that I have taken care of the distal perfusion of the limb, but what can be, क्या हो रहा है? If there is a clot, then it is not going to perfuse the limb. So you have to check that also, aspirate and check that also every day. Then हमेशा अगर आपका ये किसका है? ये है venous ECMO, right? The patient's return is in the IJV. ये नेक है ना? सो ऐसा ही लूप लगाना है। कभी कभी लोग क्या गलती करते हैं? लूप नहीं करते, स्ट्रेट कनेक्ट कर देते हैं। तो स्ट्रेट कनेक्ट करने का मतलब यू आर नॉट अलाइंग फॉर मूवमेंट। तो हमेशा एक गुड लूप लगाना है ताकि ट्रैक्शन ना हो। अगर स्ट्रेट होगा तो पुल आउट आसानी से हो जाएगा। ऑलराइट, देन कलर ऑफ द ट्यूबिंग आई हैव ऑलरेडी एक्सप्लेन। रिमेंबर, देयर शुड बी अ गुड कलर एट ऑल टाइम्स। अगर दोनों का कलर ब्राइट रेड हो गया तो रिसर्कुलेशन हो रहा है वीवी एक्मो में, वीए में कोई मतलब नहीं है इसका। लेकिन अगर दोनों का प्रोडक्ट ब्राइट डार्क हो गया तो मतलब कुछ प्रॉब्लम है, ऑक्सीजन सप्लाई चेक करो। ऑलराइट, देन सर्किट पैरामीटर्स एंड प्रेशर। यू हैव टू मॉनिटर एसेंशियली 3 प्रेशर्स, P1, P2 एंड P3। तो P1 प्रेशर क्या है? पंप से पहले है, ये मदद करता है ब्लड को ड्रॉ करने में। तो हमेशा जो चीज खींचेगी, नेगेटिव सक्शन क्रिएट करेगी, तो वो प्रेशर क्या होगा? हमेशा नेगेटिव होगा। तो प्रेशर विल बी अराउंड -20 to -70। ऑलराइट, दिस प्रेशर इज गोइंग टू बी अराउंड -20 to -70, है ना? तो लेकिन अगर आपने पेशेंट को एक्मो पे कनेक्ट किया, आपने एक आरपीएम डाला ताकि एक अमाउंट ऑफ ब्लड फ्लो जनरेट हो, लेकिन आपका प्रेशर और नेगेटिव होता चला जा रहा है, इसका मतलब है आपके पंप को और एफर्ट लगाने पड़ रहा है और साथ में आपका ब्लड फ्लो उतना अचीव नहीं हो रहा सेम आरपीएम पे। इसका मतलब क्या प्रॉब्लम है? उस पंप को सक करने में दिक्कत आ रही है। तो सक करने में दिक्कत किस वजह से हो सकती है? आइदर रिजर्वॉयर ब्लड ही नहीं है, हाइपोवोलेमिया है, या आपकी कैनुला यहाँ पर किंक पड़ी हुई है। तो कोई भी चीज अगर लाने में, ब्लड को ड्रॉ करने में दिक्कत करेगी पंप को, तो ये अलार्म बहुत तेजी से नेगेटिव होने लगेगा, विच इज अ कैटास्ट्रोफिक। तो जैसे ही आपका अलार्म नेगेटिव होने लगे तो आपको क्या करना है? इमीडिएटली क्या करना है? इमीडिएटली क्या करना है? इमीडिएटली पहले पंप की स्पीड को थोड़ा कम करना है ना? कि भाई तुम शांत हो जाओ, जितना फ्लो में कम फ्लो कर, आपकी डिमांड को हम कम कर देते हैं। तो अभी आपकी डिमांड को कम कर दिया, फर्स्ट स्टेप। सेकंड स्टेप, यू विल गिव वॉल्यूम, एंड देन थर्ड स्टेप, नाउ दैट योर ECMO इज अगेन स्टार्टिंग टू रन, आपको क्या करना है? यू हैव टू देखना है कि क्या प्रॉब्लम हो रही है ना. बट अगर आपने पंप की स्पीड को बहुत ज्यादा कम कर दिया, बी माइंडफुल दैट यू मे हैव टू इंक्रीज द हेपरिन, है ना, एसीटी करना है. और ठीक है, P2 प्रेशर क्या होता है? P2 pressure is post pump but it is pre-oxygenator. P3 is both post pump and post oxygenator. P2 और P3 क्या है? दोनों पॉजिटिव होंगे, है ना. अच्छा, अगर यहां पर कोई ऑब्स्ट्रक्शन आ रहा है, सपोज your P1 is okay, forget, but your P2, P3 alarms are blowing, है ना. यहां पर कोई ऑब्स्ट्रक्शन है तो कहां का प्रेशर बढ़ेगा? बैकस्ट्रीम होता है. जब भी कोई सिद्धांत है ना कि कहीं पे कोई पत्थर लगा है तो उसके पीछे की जितनी चीजें हैं बढ़ने लगेंगी. तो ये पेशेंट आपका आर्टरी में है, अब यहाँ पर चलेंगे, पेशेंट का ब्लड प्रेशर बहुत ज्यादा बढ़ जाए, यानी कि एसवीआर बढ़ जाए, या यहाँ वाली कैनुला ऑब्स्ट्रक्ट करने लगे, या यहाँ पर कोई क्लॉट आ जाए, तो कहाँ का प्रेशर बढ़ जाएगा? ये भी बढ़ जाएगा, P3 प्रेशर भी बढ़ जाएगा, P2 प्रेशर भी बढ़ जाएगा. ऑलराइट. तो लेकिन अगर यहाँ पे कोई प्रॉब्लम नहीं है और यहाँ पर कुछ प्रॉब्लम, ये क्या है? ऑक्सीजन. अगर यहाँ पे कोई प्रॉब्लम आ गई, कोई क्लॉट हो गया या मैल फंक्शन हो गया, तो क्या हो गया? क्या ये बढ़ेगा? नहीं बढ़ेगा. क्या बढ़ेगा? P2 बढ़ेगा. तो P2 विल राइज, P3 विल ड्रॉप. सो इसी को बोलते हैं डेल्टा प्रेशर. ऑलराइट. सो इफ P2 and P3 both are increasing, तो डेल्टा प्रेशर विल बी नॉर्मल. देन प्रोबेबली पेशेंट को सडन एसवीआर हो गया, ये पेशेंट हिलने डुलने लगा, या रिटर्न कैनुला में कोई किंक आ गया, या कोई मासिव क्लॉट या ट्विस्टिंग हो गई, तो देन यू हैव टू रिलीव दैट. बट अगर सिर्फ P2 बढ़ रहा है, P3 नहीं बढ़ रहा और डेल्टा प्रेशर बढ़ रहा है, इसका मतलब है कि ऑक्सीजनेटर क्लॉग हो रहा है. तो अब क्या करें? ऑक्सीजन निकाल के फेंक दें? क्या करेंगे? हेपरिन देंगे. वेरी गुड. और क्या करेंगे? चेक करेंगे ऑक्सीजनेटर. हमने देख लिया कि ऑक्सीजनेटर में क्लॉट है और हेपरिन भी हमने बढ़ा दी. अब क्या करें? अलार्म तो है, हमने एक्सेप्ट कर लिया जो थोड़ा अलार्म. अब क्या करें? क्या हम ऑक्सीजनेटर चेंज करेंगे? चूंकि इट इज अ फॉरेन सर्किट, फॉरेन बॉडी है ना, सॉरी नॉट अ फॉरेन, इट्स एन एक्स्ट्रा कॉर्पोरियल सर्किट, तो धीरे धीरे डेल्टा प्रेशर तो राइज करेंगे. क्यों? क्योंकि धीरे धीरे ऑक्सीजनेटर तो क्लॉट करेगा ही, है ना. सो आपके अलार्म्स तो बढ़ेंगे ही, बट यू हैव टू सी कि कैन यू मेक अ कॉम्प्रोमाइज बिटवीन द हायर डेल्टा प्रेशर एंड द गुड ऑक्सीजनेशन. तो हमेशा क्या करना है? ऑक्सीजनेटर के बियॉन्ड, यहाँ पर जो जहां से आप प्रेशर मॉनिटरिंग लेते हो ना, वहां पर एक ब्लड सैंपलिंग पोर्ट होता है ना, आप क्या करोगे? ब्लड ड्रॉ करोगे. सर्किट का पोस्ट ऑक्सीजनेटर सर्किट का एबीजी करोगे. अगर आपका PaO2 ठीक है, इफ इट इज मोर देन 200 राइट, हाउ मच? 200. अगर 250 तक है और PCO2 भी ठीक है, यानी कि बढ़ नहीं रहा, 50-60 से ज्यादा नहीं है, then you ignore that for the time being. What you do is, yes, you do need to increase the heparin levels. You need to be mindful कि patient को कोई clotting या DIC तो नहीं हो, क्योंकि just like body में कहीं clot होगा तो DIC होगा, वैसे circuit में भी clot होगा तो circuit तो patient से attached है ना. तो अगर सर्किट में क्लॉट हो रहा है तो कहीं कोई उसका हीमोग्लोबिन पेशेंट का ड्रॉप तो नहीं हो रहा, उसको हीमोग्लोबिनूरिया तो नहीं हो रहा, उसको डीआईसी के कोई फीचर्स तो नहीं हो रहे, देन इन दैट केस नीड टू चेंज. बट सिर्फ आपका डेल्टा प्रेशर बढ़ रहा है, इसका मतलब ये नहीं कि आप ऑक्सीजनेटर निकाल के फेंक दो. नहीं, यू हैव टू चेक द पोस्ट ऑक्सीजनेटर ब्लड गैस. ऑलराइट. P1 प्रेशर बता दिया, P2 बता दिया, एंड रिमेंबर दैट इनकी P2 P3 प्रेशर या P1 प्रेशर की कोई एब्सोल्यूट वैल्यू नहीं होती है. These are all relative value. आप हमेशा उनको पिछले दूसरे घंटे से कंपेयर करते हो. आप समझ रहे हो? क्योंकि आपके पेशेंट का फ्लो, अगर पेशेंट का सर्किट बहुत अच्छा चल रहा है, अगर आपने किसी को 4 लीटर के फ्लो पे सर्कुलेट करा रहे हो एक्मो, तो उसके डेल्टा प्रेशर, उसके P1 P2 3 प्रेशर हमेशा हायर होंगे, क्योंकि आप ज्यादा एनर्जी से सक कर रहे हो. और अगर आप लोअर फ्लो पे कर रहे हो तो हमेशा प्रेशर्स कम होंगे. सो एब्सोल्यूट वैल्यूज आर माइंडलेस. इट इज द relative change which is important. All right. Then डेल्टा प्रेशर भी एक्चुअली अब क्या देखना है सर? सॉरी, व्हाट इज दिस? दिस इज द कंसोल. एक्मो कंसोल में एक ही चीज होती है जो देखने की है, वो है राउंड्स पर मिनट. और उस राउंड्स पर मिनट क्या होता है कि कितनी तेजी से मोटर घूम रही है, और उस राउंड्स पर मिनट या रेवोल्यूशन पर मिनट पे कितना आपने ब्लड फ्लो मशीन दे पा रही है. ऑलवेज अगेन यू हैव टू कंपेयर, अलग अलग मशीन की अलग अलग कैपेसिटी होती है. व्हाट इज मोर इम्पोर्टेंट कि आज अगर 3500 राउंड पर मिनट पे द ECMO इज गिविंग ड्रॉइंग अ ब्लड ऑफ 4.4, बट टुमारो इफ यू कम एंड विद द सेम रेवोल्यूशन द ECMO का फ्लो कम हो रहा है, इसका मतलब धीरे धीरे इसकी कैपेसिटी कम हो रही है, फ्लोज कम हो रहे हैं, कहीं कोई क्लॉट तो नहीं हो रहा वीनस साइड में जो अब धीरे धीरे बिल्ट अप कर रहा है ना. और अगर ऐसा हो जाए कि राउंड्स आप 3500 दे रहे हो और फ्लो सेट नहीं हो रहा है, 1 हो रहा है, 2 हो रहा है, ऐसे ऐसे जल्दी जल्दी भाग रहा है और P1 प्रेशर अलार्म बोले जा रहा है, इसका मतलब दिस इज अ इमरजेंसी सिचुएशन कि बहुत ही इरेटिक फ्लोज आ रहे हैं. इसका मतलब कोई ऑब्स्ट्रक्शन हो रहा है या पेशेंट को इमीडिएट हाइपोवोलेमिया हो गया है या इतना वेसोसेप्सिस हो गया है जिसकी वजह से हाई कार्डियक आउटपुट हो गया है ना, या there is some kinking. So in that case you have to come down on the flow, give some volume of fluid and see that what is the problem with the patient. All right. So same RPM decrease flow can either be to decrease preload, यानी कि पेशेंट में हाइपोवोलेमिया, कैनुला मैलपोजिशन, वीनस की ट्यूब लिंक है, या इंक्रीज्ड आफ्टर लोड है. अगर आफ्टर लोड भी इंक्रीज कर गया तो भी पेशेंट विद द सेम RPM the ECMO will not provide the consistently good flow. All these causes. Then there is a, what is this? This is a blender unit. All right. ये क्या करती है, ये जो हम ऑक्सीजनेट कर रहा है तो वो जो उसमें ऑक्सीजन पास हो रही है वॉल माउंटेड सोर्स से, वो क्या होती है, वो पहले ब्लेंडर के थ्रू जाती है. तो मोस्टली अब मुझे लगता है आप लोग या तो टेक्नीशियंस हो या एनेस्थीसिया बैकग्राउंड है आपका, तो आपको इट इज द सेम थिंग. जो ब्लेंडर होता है ना, एनेस्थीसिया वर्क स्टेशन में ब्लेंडर होता है, एक क्या होता है, फ्रेश गैस फ्लो होता है, उसको हम यहाँ क्या बोलते हैं, स्वीप गैस फ्लो बोलते हैं, और एक हम FiO2 एडजस्ट करते हैं. ठीक है. तो फ्रेश गैस फ्लो क्या करते हैं, वी हैव टू मैच इट विद द ब्लड फ्लो. तो अगर मैंने अपने पेशेंट को ECMO फ्लो दे रहे हैं 4, तो माय गैस फ्लो शुड, फ्रेश स्वीप गैस फ्लो शुड आल्सो बी 4. It can be 3.5, it can be 4.5, but there cannot be a huge mismatch. Okay. तो अगर कभी भी हम अपना ECMO का फ्लो घटा या बढ़ा रहे हैं तो हमें उसी रेशियो में, उसी अनुपात में गैस का फ्लो भी घटाना और कम करना है. राइट. और FiO2 क्या है, FiO2 21% से 100% तक जाते. शुरू में ECMO लगाएंगे तो सभी में हम क्या करेंगे, FiO2 100% लगेंगे, धीरे धीरे वी आर गोइंग टू टाइट्रेट. All right. Why do we don't want this thing, क्या कहते हैं, हमको स्वीप गैस फ्लो मैच क्यों कराना है पम्प फ्लो से? Yes, because what Atithar told, if you remember, that the oxygenation is dependent on many factors, which depends on the oxygenator की quality, cloud, but जो CO2 होती है वो तो soluble होती नहीं है, तो वो क्या होती है, CO2 बहुत जल्दी वाइप ऑफ हो जाती है. तो स्वीप गैस फ्लो इज द ओनली फैक्टर दैट इज गोइंग टू डिटरमाइन कि CO2 कितनी जल्दी एग्जॉस्ट बॉडी से एलिमिनेट होगी. सो यू ऑलवेज हैव टू बी माइंड, इसीलिए कपलिंग बहुत जरूरी है. एंड यू कैन नॉट, ऐसा नहीं कि सडनली ये होता है. दिस ऑल्सो प्रॉब्लम वी एनकाउंटर्ड. आई हैड अ रेजिडेंट एंड व्हाट ही डिसाइडेड कि सैचुरेशन तो इंप्रूव नहीं हो रहा है, अभी पेशेंट का सैचुरेशन 65% हो गया, तो मैम ने तो बोला कि वेंटिलेटर को नहीं छेड़ना, वेंटिलेटर से कोई मतलब नहीं है, तो ऐसा करते हैं इसका गैस फ्लो, फ्रेश गैस फ्लो बढ़ा देते हैं. तो फ्रेश गैस फ्लो से तो ऑक्सीजनेटर इज ओनली वन फैक्टर ना. तो फ्रेश गैस फ्लो बढ़ाने से क्या हो जाएगा, suddenly CO2 wash हो जाएगी. And sudden CO2 wash out, we all know, hypercapnia doesn't kill, but hypocapnia kills. Hypocapnia kills the brain. Sudden CO2 wash out decompensates the brain. There can be raised ICP, patient can have seizures, even it can cause infarcts and also hemorrhage. IVH, इंट्रावेंट्रिकुलर हीमरेज कर सकता है, सेरेब्रल हीमरेज कर सकता है. तो ऑलवेज जब भी आप फ्लो को घटा बढ़ा रहे हो तो हमेशा गैस फ्लो को भी उसी अनुपात में घटाओ बढ़ाओ. ऑलराइट. देन क्लिनिकल एंड वाइटल साइंस इज आल्सो इंपॉर्टेंट. ऑलरेडी अतिहर्ष टोल्ड कि VA ECMO में सैचुरेशन का तो कोई मतलब नहीं है, पल्सेटिलिटी ही बहुत कम होती है, 10% होती है पल्स. व्हाट यू हैव टू डू इज यू हैव टू लुक एट द PO2, बट PO2 भी डिपेंड करेगा कि किस पार्ट ऑफ द बॉडी से कर रहे हो. नॉर्मली हम क्या करते हैं, राइट साइड के हैंड को कैनुलेट करते हैं. क्यों? क्योंकि आपका जो रिटर्न जा रहा है वो जा रहा है, कहाँ जा रहा है, डिसेंडिंग पार्ट ऑफ एओर्टा में, है ना. सो ब्लड रिटर्न हो रहा है डिसेंडिंग पार्ट ऑफ एओर्टा में, यहां से हार्ट आपका पंप कर रहा है. ऑलराइट, तो क्या हो रहा है, हार्ट इज ऑल्सो पंपिंग एंड दिस इज ऑल्सो. अगर हार्ट बहुत कम पंप कर रहा है तो सारा ही डिसेंडिंग एओर्टा से रेट्रोग्रेड फ्लो होकर सारी ब्रेकियोसेफेलिक ट्रंक को परफ्यूज करेगा. तो ब्रेन को कहाँ की सप्लाई मिलेगी, रिटर्निंग ब्लड फ्लो की मिलेगी, तो कोई प्रॉब्लम नहीं है. बट व्हाट हैपेंस इज दैट देयर इज समथिंग कॉल्ड गुड हार्ट एंड बैड लंग सिंड्रोम. ये जनरली फर्स्ट डे सेकेंड डे से आना शुरू हो जाता है कि जब मेटाबॉलिक एसिडोसिस करेक्ट हो गया, चूंकि पेशेंट इज ऑन एक्मो, अदर फैक्टर्स हैव करेक्टेड, तो हार्ट की कॉन्ट्रैक्टिलिटी आने लगती है. बट लंग इज स्टिल बैड इफ द पेशेंट ऑल्सो हैज अ बैड लंग बाय द वे. तो लंग इज स्टिल बैड, तो क्या होगा, ये दोनों फ्लो आपस में क्या करेंगे, फाइट करेंगे. तो जो हार्ट के पास वाली वेसल्स हैं, जो ब्रेकियोसेफेलिक ट्रंक है उसके पार्ट वाली वेसल्स हैं, जैसे कि यहाँ की सबक्लेवियन एंड ब्रेन, है ना. तो इनको क्या होगा, ब्रेन की राइट साइड की इंटरनल कैरोटिड, इनको कहां से ब्लड मिलेगा, इनको हार्ट की नेटिव सर्कुलेशन से ब्लड मिलेगा, जो कि रिलेटिवली हाइपोक्सीमिक है बिकॉज वो लंग से पास होके आया है. तो ऐसे केस में क्या होगा, यहां पर जब तुम PO2 या यहाँ का सैचुरेशन हमेशा कम होगी, तो आप कहोगे कम होने तो क्या फर्क है, यहाँ की 95 आ रही है, यहाँ की 70 आ रही है, तो क्या हुआ. It's okay, it will do for patient, but why it is important, because you are not measuring the brain. अगर यहाँ की सैचुरेशन कम होने का मतलब क्या है, ब्रेन की भी सैचुरेशन कम हो रही है. तो अब इस केस में क्या करें, हार्ट तो ठीक हो रहा है, क्या एक्मो बंद कर दें, बंद तो नहीं कर सकते क्योंकि अभी तो लंग भी खराब है. तो व्हाट डू वी डू, वी गो ऑन अ हाइब्रिड एक्मो, वी पुट अनदर VAV एक्मो. जो रिटर्न है, अभी तक हम A पे कर रहे थे, अब हम एक पार्शियल रिटर्न कहाँ ले लेंगे, IJV में ले लेंगे. तो उससे क्या होगा, जो आपके लंग को भी ऑक्सीजन मिलेगा, वो क्या मिलेगा, रिलेटिवली गुड. तो यहाँ की प्रॉब्लम सॉल्व होएगी कि नहीं सॉल्व हो. और अगर आपका हार्ट एकदम इंप्रूव हो गया, देन यू डोंट नीड VA एक्मो, सो आप उसको कंप्लीटली स्विच कर सकते हो VV एक्मो में. गेटिंग माय पॉइंट. सो दिस इज द सेम थिंग दैट. और अगर ऐसा हो कि हार्ट बहुत अच्छा हो गया, बहुत अच्छा हो गया हार्ट का, तो क्या होगा, यहाँ का पूरा भाग नीला इन द सेंस नीला होता नहीं, मतलब हाइपोक्सीमिक, एंड below part of the body will be hyperoxemic. तो इसको ये जो गुड हार्ट बैड लंग सिंड्रोम है या हार्लेकिन सिंड्रोम है, ये डिपेंडिंग ऑन द कॉन्ट्रैक्टिलिटी ऑफ द हार्ट अलग अलग तरीके से प्रेजेंट कर सकता है. ऑलराइट, आर्टीरियल ब्लड प्रेशर मैप कितना टारगेट करना है, 65 to 70. जब भी हम VA एक्मो पे डालेंगे पेशेंट को, हमको वेजोप्रेसर बंद कर देने. ऑलराइट, ठीक है. लेकिन जब हम अगर हमारा गुड एक्मो चल रहा है तो क्या हो जाएगा, सिस्टोलिक फॉल कर जाएगा, डायस्टोलिक फॉल कर जाएगा. पल्स प्रेशर कितना रह जाना चाहिए, 0 नहीं, 10, एटलीस्ट 10, इतना तो रखो. लेकिन मैप आपको पता है ना कि पल्स प्रेशर चेंज होने से या सिस्टोलिक डायस्टोलिक होने से मैप नहीं चेंज होता है ना. तो इवन इफ देयर इज लिटिल पल्स, हाउ डू यू नो दैट योर एक्मो इज फंक्शनिंग वेल, VA एक्मो इज फंक्शनिंग वेल, द मैप इज 55 and above. That means all parts of the body are receiving good circulation. All right. Pulse contour dampen होनी चाहिए, लेकिन completely zero नहीं होनी चाहिए, है ना. Completely cardiac stunning नहीं करानी है. Pulse pressure around 10 तो रखना ही रखना है. Decreased pulse pressure is a sign of cardiac stunning, that your patient has gone on total bypass. तो क्या करना है, थोड़ा फ्लो को कम करना है, या फ्लो भी कम कर दिया तो क्या करना है, थोड़ा सा आइनोट्रोप्स हमको लगाना पड़ सकता है ना. इंक्रीज पल्स प्रेशर क्या है, इफ सडनली आपका पल्स प्रेशर 10 15 पे चल रहा था एक्मो और आपका पल्स प्रेशर स्पॉन्टेनियसली इंप्रूव कर गया, तुरंत डू एन एक्को एंड सी कि कहीं मेरा पेशेंट इंप्रूव तो नहीं कर रहा है. इसका मतलब पेशेंट का अपना सर्कुलेशन इंप्रूव कर रहा है, कॉन्ट्रैक्टिलिटी इंप्रूव कर रही है. Again, you have to also look at the patient heart and respiratory. अगर higher heart rate, tachycardia, tachyarrhythmia, both are going to lead to inconsistent drainage. फिर आपका P1 alarm करता चला जाएगा. So you need often you need to sedate the patient, है ना. It is very difficult कि initial stages of ECMO में आप patient को एकदम awake रखो. So you have to take care of anxiety, उसका volume status, arrhythmias, all these things you have to take care of. Otherwise अगर कितनी tachycardia होगा तो अच्छा flow achieve नहीं कर पाएंगे. Then saturation, as I said कि VV ECMO में saturation इसमें तो मैंने 85 लिखा है, up to 75 is also acceptable because lung is still not improved, right? Blood flow, SpO2 is a reliable marker of oxygenation in VV-ECMO, but not in V-ECMO, because V-ECMO में यहाँ का circulation 100 भी आ रहा है, but हार्ट आपका पेशेंट का हार्ट एकदम स्टैंड स्टिल भी हो गया, तो इसको तो नॉन पल्सेटाइल फ्लो मिल रहा है ना बॉडी के लेफ्ट हैंड को, है ना? तो क्या होगा, सैचुरेशन यहाँ का कुछ भी आ सकता है, या PO2 यहाँ पर अगर कैनुला डाली तो PO2 कैन बी 400, बट दैट डजंट मीन कि पेशेंट इज इंप्रूविंग. सो हम SpO2 इसे टारगेट नहीं करते हैं, हम रैदर VA-ECMO को कैसे टारगेट करते हैं? VA-ECMO को हम टारगेट करते हैं इंप्रूविंग लैक्टेट से, इंप्रूविंग यूरिन आउटपुट से, मैप से, मीन आर्टेरियल प्रेशर से, है ना? ठीक है, मीन आर्टेरियल प्रेशर 60 to 70. ऑलराइट. डिफरेंशियल हाइपोक्सिया, ये ऑलरेडी आई हैव टोल्ड, गुड हार्ट बैड लंग और हार्लेकिन सिंड्रोम, ये तो दोबारा रिपीट करने की जरूरत नहीं है. देन इफ यू हैव द फैसिलिटी, इफ यू आर वेरी फॉन्ड ऑफ सेंट्रल वीनस ऑक्सीजन सैचुरेशन, यू कैन डू. अगेन सेंट्रल वीनस ऑक्सीजनेशन वुड बी अ गुड मार्कर इन VA बट नॉट इन VV. क्यों? क्योंकि जो आपका जो भी मिक्सिंग होगी ना, VV-ECMO में तो सीरीज में चल रहा है, तो जो रिटर्निंग ब्लड है वो RA में जाएगा, और आप वहां से, और RA के बाद कहाँ जाएगा? लंग में जाएगा. RA RV, then it will go to the lung. All right. So there is going to be mixing of both the chamber, both the kind of blood. So central venous oxygen saturation is not a good marker, है ना? But you can also do the circuit venous oxygen. जो ये आपका रिटर्न कैनुला, ड्रेनेज कैनुला है, ड्रेनेज कैनुला के P1 प्रेशर, मतलब प्रायर टू द पंप, अगर आप उसकी ऑक्सीजन मेजर करोगे, दैट शुड बी ऑलवेज अराउंड 70%. अगर बहुत कम है तो गड़बड़ है, बहुत ज्यादा है तो खुश नहीं होना है, गड़बड़ है. उसका क्या गड़बड़ हो सकती है? अगर सर्किट वीनस ऑक्सीजन सैचुरेशन बढ़ गई तो इसका मतलब क्या है? इसका मतलब रिसर्कुलेशन कुड बी हैपनिंग ना, क्योंकि आप जो यहाँ से जो ऑक्सीजनेटेड ब्लड डाल रहे हो वो हार्ट के थ्रू लंग में गया ही नहीं, वो यहाँ की कैनुला ने वापस सक कर लिया. तो वीनस ऑक्सीजन सैचुरेशन होना इज अ मार्कर ऑफ रिसर्कुलेशन. ऑलराइट. न्यूरोलॉजिकल मॉनिटरिंग भी करना बहुत जरूरी है. ये नहीं कि पेशेंट को ECMO पे डाल दिया, पैरालाइज कर दिया, उसको भूल गए, ऐसा नहीं. You have to do the neurological monitoring also, and you have to give sedation holidays and check pupillary reaction every 2 minutes. And in neonatal neonates, they are at high risk of IC bleed, तो neonatal cranial ultrasound करना भी जरूरी है. This is the NIRS tool. I think if you are from anesthesia background, you must all know कि NIRS हम करके पता कर सकते हैं कि ब्रेन में ऑक्सीजन का यूटिलाइजेशन है कि कितना है. अगेन 70% होना जरूरी है. अगर कम है तो खराब है, ज्यादा है तो इसका मतलब सेल डेथ हो रही है. इट्स जस्ट लाइक ऑक्सीजन एक्सट्रैक्शन. अगर डेथ हो गई तो ऑक्सीजन एक्सट्रैक्शन होगा ही नहीं. सो यू हैव टू कीप इट अराउंड 65 to 70. All right. Then temperature monitoring is also very important. What is you have to be कि hypothermia तो बिल्कुल नहीं कराना, because hypothermia is a recipe for disaster. It can lead to not just arrhythmia, but it can also lead to DIC, and hence coagulopathy, and hence sepsis, and all these things that come with it. फिर vascular status, हमेशा limb का, अगर आपने VA-ECMO डाला है तो हमेशा क्या करना है? पैर पे नजर रखनी है, जिस पैर पे रिटर्न डाला है, कि कहीं आपका पेशेंट का लिम्ब का परफ्यूजन कॉम्प्रोमाइज तो नहीं हो रहा, DPF डिस्टल परफ्यूजन कैनुला इज वर्किंग वेल और नॉट. सो अगर आपको जरा सा भी कॉम्प्रोमाइज हो रहा है, गेट एन अल्ट्रासाउंड, गेट अ डॉपलर पल्स देखने के लिए, है ना. दिस इज ऑल्सो अ वेरी कॉमन प्रॉब्लम. तो कलर, कैपिलरी रिफिल टाइम शुड ऑलवेज बी मोर देन 3 seconds, है ना. अगर इडीमा, वीनस कंजेशन हो रहा है, देन ऑल दिस प्रॉब्लम. देन यूरिन कलर इज ऑल्सो इम्पोर्टेंट. यू हैव टू मॉनिटर यूरिन कलर. शुरू में क्या होता है, जब ECMO पे डालते हैं तो अप टू 24-48 आवर्स, क्योंकि इंटेंस सर्स होता है तो यूरिन आउटपुट डिप करता है, तो उस समय शॉर्ट डोज ऑफ डायरेटिक्स देनी पड़ती है. बट आफ्टर दैट अक्सर ये होता है कि ECMO पे डाला तो बहुत ज्यादा यूरिन आउटपुट आता है ना. So you have to be mindful at that. Also urine color, everybody knows sign of dehydration है, but हमको यहाँ सबसे ज्यादा importance क्या है? hemolysis देखनी है. Dark color urine, reddish tinge urine is a sign of hemolysis. और ये डेंजरस है. Why? Because hemolysis तो पेशेंट में थोड़ी बहुत होगी ही, सर्किट में होगी, क्योंकि जैसे जैसे सर्किट चलेगा आप कितना भी कर लो, you cannot avoid it. There will be some thrombosis, some clot in the oxygenator, some amount of clot anywhere. But अगर वो जरूरत से ज्यादा हो गया, then it is going to cause widespread thrombosis, patient में thrombosis, and it will cause DIC. And having blood in urine is a marker of DIC. Low hemoglobin, rising lactate, haptoglobin levels, है ना, LDH बढ़ रहा है, ये सारी चीजें हेमोलिसिस शो कर रही है. तो इसका मतलब 2-3 चीजें होती है, या तो पेशेंट हाइपोथर्मिक है या उसको सेप्सिस हो रहा है. लेकिन सबसे इंपॉर्टेंट कॉज जो आप कर सकते हो वो ये चेक करना कि कहीं सर्किट में क्लॉटिंग तो क्या बोलते हैं, निश्चित मात्रा से ज्यादा नहीं हो गई. अगर निश्चित मात्रा से ज्यादा हो गई तो देन यू हैव टू आइदर थिंक कि पेशेंट इंप्रूव हो रहा है तो एक्मो से हटा ले, अदरवाइज यू हैव टू चेंज द एंटायर सर्किट और द affected component of the circuit. All right. Or biochemical monitoring. This obviously you need good hemoglobin levels. जैसा कि मैंने बताया था कि you don't need platelet of 1 lakh. If platelet more than 30,000, if there is no bleed, but if any procedure needs to be done or if there is bleeding, then you need platelet more than 75,000. And mind you, जब आप पेशेंट को why do I keep saying ventilator? पेशेंट को जब आप ECMO पे लेते हो तो प्लेटलेट फॉल करते ही करते हैं. पेशेंट 1.5 लाख पे आपने लिया था, पेशेंट का अगले दिन आपको मिलेगा ही 75,000. तो डोंट माइंड, देयर इज सो लॉन्ग देयर इज नो ब्लीडिंग, डोंट बी माइंडफुल, बट ऑलवेज हैव बैकअप प्रोडक्ट्स रेडी. ऑलराइट. क्योंकि क्यों शुरू में 24-48 आवर्स में ऐसा क्यों हो रहा है कि प्लेटलेट भी कम हो रहे हैं, यूरिन आउटपुट भी कम हो रहा है. लंग में भी हमने तो पेशेंट को सोचा था कि ठीक हो जाएंगे लंग, उसके लंग में और इन्फिल्ट्रेट्स आ गए. क्यों? क्योंकि ये फॉरेन बॉडी है ना, ये एक सर्स रिस्पॉन्स क्रिएट करेगी. एक तो सर्स रिस्पॉन्स की वजह से क्या होगा, लीकी कैपिलरीज, एडिमा होगा, तो उसकी वजह से थोड़ा पल्मोनरी एडिमा भी आएगा, प्लेटलेट भी कंज्यूम होंगी और साथ में यूरिन GFR भी कॉम्प्रोमाइज होगा. बट डोंट वरी, पूरा जब सिक्वेस्टर हो जाएगा सर्किट तो ये सारी चीजें कम हो जाएंगी. और अब फिर भी तुमको डर लग रहा है तो यू कैन गिव अ शॉर्ट डोज ऑफ स्टेरॉइड टू काउंटर एक्ट दैट सर्स रिस्पॉन्स. ऑलराइट. Then blood gas again. क्या कहाँ की ब्लड गैस बोली थी इंपॉर्टेंट है, पेशेंट की इंपॉर्टेंट है. ऑल राइट. एंड सर्किट की इंपॉर्टेंट. सर्किट में 2 जगह इंपॉर्टेंट है. एक तो प्री पंप सर्किट वीनस ऑक्सीजन सैचुरेशन के लिए देखने के लिए, है ना. और पोस्ट ऑक्सीजनेटर क्यों इंपॉर्टेंट है, रोज नहीं करना है, पर जब आपको लगे कि डेल्टा प्रेशर बढ़ रहा है ना. आई टोल्ड यू इन द बिगनिंग ना कि अगर डेल्टा प्रेशर बढ़ रहा है तो ऑक्सीजनेटर फेल तो कंप्लीटली हो रहा है कि नहीं, ये देखने के लिए हमें क्या करना है, पोस्ट ऑक्सीजनेटर ब्लड क्लास करनी. अगर हमारा PO2 जो है, पोस्ट ऑक्सीजनेटर PO2 200 से ज्यादा है तो टाइम है, घबराने की जरूरत नहीं है. जस्ट इंक्रीज द हेपरिन, इंक्रीज द ब्लड फ्लो. ऑलराइट. रीनल फंक्शंस अगेन वेरी इंपॉर्टेंट. कोऑगुलेशन पैरामीटर मॉनिटरिंग बता चुके हैं. यू हैव टू कीप ACT of around 160 to 200 in VV ECMO, and how much higher, 180 to 200 in V ECMO, because V ECMO will generate at a lower pump flow. All other coagulation parameters also you can do, but not as routinely as ACT, because most of the times patient will be on heparin, है ना. Ergotroban and all those things, fancy things, except bilavirudin we don't really get. Antithrombin 3 मैं तो कभी हमें नहीं कराया, बट ideally it should be done because with time there will be heparin resistance and heparin needs anti-3 in the body. So if due to any factor there is no decreasing anti-3 level, तो आपका heparin तो बढ़ता चला जाएगा, but patient का ACT नहीं improve बढ़ रहा, तो इसका मतलब anti-3 thrombin level करने की जरूरत है. और अगर anti-thrombin कम है तो क्या होगा, क्लॉटिंग के चांस है. तो कैसे रिडीम करना एंटीथ्रोम्बिन 3 को, give FFP. It contains 1 or 2 doses of FFP. It contains antithrombin 3. Then monitoring for hemolysis I have already told, है ना. DIC or any clot or extreme cavitation, extreme negative P1 pressure, it will also cause hemolysis. तो उसको आपको avoid करना है. These are the indicators: dark colored urine, high bilirubin, lower platelets, increase LDH, increase plasma free hemoglobin. वैसे भी time to time circuit की blood लेकर उसको plasma free hemoglobin के लिए check करना चाहिए. अगर plasma free hemoglobin 10 से ज्यादा हो रहा है, इसका मतलब circuit में clotting निश्चित मात्रा से ज्यादा हो रही है ना? Then you have to take decision. All right. Radiological monitoring I've already told in detail, right? Radiological means looking at the X-rays for the position of the cannulas so as to avoid recirculation. During placement also you need to do 2D echo. Here you can see कि cannula सही डाला था but perforate कर गया, and you can see the pericardial effusion. Also have a look at this video. Is it running or not? No. So this was a video. I don't have the parent video maybe in the slide. So this was a video which was showing cardiac stunning. बिल्कुल heart का ये देखो, this is the left ventricle chamber. It has almost dilated और इसकी contractility कम होती चली जा रही है. फिर इससे क्या problem हो सकती है? There can be LV stasis and there can be pulmonary edema. And LV clot can also form. ये सारी चीजें कैटास्ट्रोफिक है. तो ऐसे केस में क्या करोगे? पंप फ्लो को थोड़ा कम कर दोगे. वेरी गुड. एंड गिव सम आइनोट्रोप्स. थोड़ा हार्ट को सपोर्ट करो. अल्ट्रासाउंड ऑलरेडी आई हैव ऑलरेडी टोल्ड एट वेरियस पॉइंट्स यू नीड. व्हाई डू वी नीड एन एब्डोमिनल अल्ट्रासाउंड बाय द वे? अगर हाइपोवोलेमिया हो रहा है, जब हम जो ये एक्सिस कैनुला डालते हैं ना, हम फिमोरल वेन या आर्टरी के थ्रू डालते हैं, अगर ये थ्रू एंड थ्रू पास हो गई तो रेट्रोपेरिटोनियल हिमेटोमा होने के चांसेस होते हैं. आपने सब कुछ सेट कर दिया और आपको लग रहा है कि फ्लो आ जाना चाहिए था, फ्लो आया नहीं. क्यों? क्योंकि आर्टरी को या वेन को इरोड करके कहां चला गया कैनुला? रेट्रोपेरिटोनियल. सो ऑलवेज समटाइम्स इफ यू कैन नॉट अंडरस्टैंड व्हाई पेशेंट इज क्रैशिंग, get an abdominal ultrasound. Then ventilatory parameters I've already told that you have to keep the patient on rest ventilator setting. Keep PIP less than 25 at all times. Check compliance should always be more than 20. Tidal volume कितनी रखनी है? हाई नहीं रखनी, उतनी tidal volume रखनी है जितना कि रेस्ट पे अलाउ करे, है ना? सो प्लेटो प्रेशर 25 से नीचे रखना चाहिए हमेशा. और जैसे जैसे लंग इंप्रूव करेगा, देन यू कैन गो ऑन मॉडरेट वेंटिलेटर सेटिंग. एंड FiO2 शुड बी केप्ट एज लो एज पॉसिबल. सो होता क्या है कि अगर ऑक्सीजनेशन कम हो रहा है, किसी रेजिडेंट है उसको नहीं पता है, तो वो क्या करेगा कि ऑक्सीजनेशन कम हो रहा है तो हम वेंटिलेटर का सब कुछ बढ़ा देते हैं. अरे PIP बढ़ा देते हैं, प्रेशर कंट्रोल बढ़ा देते हैं, या इज इट गोइंग टू हेल्प द पेशेंट? इज इट गोइंग टू हार्म द पेशेंट? Yes, it is going to harm because then you have obviated the benefit of rest ventilator setting. तो विली हो जाएगी, है ना? So all these things you have to remember. और सडनली आपने पेशेंट को रेस्ट वेंटिलेटर सेटिंग पे रखा था और आपकी कंप्लायंस सडनली इंप्रूव कर गई, तो दैट कैन बी अ गुड इंडिकेशन कि आपका पेशेंट improve हो रहा है. तो can I now try and start weaning? Let me get an X-ray chest. Let me do an ABG. So all these things are important. Weaning trial and off and decannulation, should I tell or later on? As you say. So तीन चीजें बस just remember what is it. Weaning का मतलब when you are ready, you have to start the process of taking the patient off the ECMO. तो weaning जैसे वेंटिलेटर की weaning है, weaning में क्या करना है? weaning में क्या करते हैं? फुल से पार्शियल सपोर्ट पे ले आते हैं ना, तो स्लो डिक्रीज ऑफ ECMO सपोर्ट सच एज स्वीप गैस फ्लो एंड ECMO FiO2. ऑलराइट, एंड ECMO फ्लो. देन ट्रायल ऑफ का मतलब क्या होता है? ट्रायल ऑफ का मतलब होता है जैसे ETPs ट्रायल है देते, थोड़ी देर के लिए आपने क्या किया, सर्किट से नहीं हटाया बट क्लैम कर दिया, डिस्कनेक्ट कर दिया, है ना, जिससे कि आप देखो कि विदाउट ECMO पेशेंट सस्टेन कर पा रहा है कि नहीं कर पा रहा है. एंड थर्ड, व्हेन यू थिंक दैट दीज ट्रायल्स हैव बीन सक्सेसफुल, देन यू decannulate. And decannulation is also a procedure, क्योंकि आपने बड़ी वेसल्स को कैनुलेट किया है, तो स्पेशली अगर आर्टरी को कैनुलेट किया है तो उसको डीकैनुलेशन करने के लिए भी आपको मदद चाहिए. वीनिंग क्राइटेरिया इंपॉर्टेंट है. VV ECMO का इफ यू वांट यू कैन टेक अ स्नैपशॉट कि VV ECMO में क्या क्या इंपॉर्टेंट क्राइटेरिया है. तो अगर चेस्ट एक्सरे इंप्रूव करने लगे, लंग कंप्लायंस ऑन द सेम सेटिंग इंप्रूव करने लगे, मोर देन 20 हो जाए, एबीजी इंप्रूव हो जाए, SpO2 इंप्रूव हो जाए, देन यू हैव टू थिंक अबाउट वीनिंग. वीएक्मो में इन सब से कोई मतलब नहीं ना. वीएक्मो में तो अगर प्योरली हार्ट की कंडीशन थी तो कंप्लायंस तो लंग का ठीक ही होगा, है ना. तो इन सब से कंप्लायंस में कोई मतलब नहीं. एबीजी से भी कोई. व्हाट डू यू रियली मीन टू में, अगर आपके पेशेंट का मैप स्टेबल है, हेलो मैम, सैचुरेशन इंप्रूव हो रहा है, लैक्टेट स्टेबलाइज हो रहे हैं, गुड यूरिन आउटपुट आ रहा है, और आपके जो पल्स प्रेशर 10 चल रहा था, 15 चल रहा था, सडनली इंप्रूव होने लगा, सडनली यू हैव नॉट फिडल्ड विद द ECMO, बट योर पल्स कॉन्टूर इंप्रूव होने लगा, इसका मतलब कहीं कॉन्ट्रैक्टिलिटी आ रही, तो आप क्या करोगे, देन यू विल लुक एट द इको. सो अगर इको में आपकी कॉन्ट्रैक्टिलिटी इंप्रूव हो रही है, इको में अगर टैप्सी इंप्रूव हो रहा है, वेलोसिटी टाइम इंटीग्रल इंप्रूव हो रहा है, यू सी दैट द इजेक्शन फ्रैक्शन इज इंप्रूविंग, देन probably now your time to think about weaning. So once you do weaning, then you do trial off मतलब टेम्पररी सस्पेंशन. यू कीप द ECMO सर्कुलेट. ऐसा नहीं कि उसको बंद कर दिया, उसको रन करने दो ताकि क्लॉट ना हो, है ना. एंड यू ऑल्सो give up, you increase the ventilatory support. So that is the trial off. And once you are satisfied that patient is going to sustain, then what do? You decannulate. So I'm not going to tell this because I've already, time is just rushing past, but I think at the workstation, with the help of clamps, with the help of proper circuit there, we will be able to demonstrate it better. And then decannulation एक art है. Please, आप चूंकि आपको निकालना है चीजें, तो please stop heparin for 1 hour. Completely disconnect the cannula from circuit after applying double clamp. जब आप डिस्कनेक्ट करने से के लिए क्या करना है, पुल आउट नहीं कर देना, आपको सब क्लैम्प्स लगा देने, है ना. एंड व्हाट डू यू डू, वीवी ECMO में क्या करना है, you simply pull out the cannula. And what do? You take mattress sutures and you compress it. But VA ECMO में चूंकि आपने एक रेंट मारा है आर्टरी में, तो that you at that time you may not need the CTVS surgeon at the time of insertion, but you need time at the time of removal, because he may have to take a graft and उस पैच, एक ग्राफ्ट पैच लगा के आर्टरी को एक्सप्लोर करके उसको बंद करना पड़ सकता है. लेकिन एंड फॉलो ऑल द पोस्ट डिकैनुलेशन प्रिकॉशंस. जैसे आप कुछ और प्रिकॉशन CTVS में, तो वैसे ही यू हैव टू कीप द लिम्ब इमोबिलाइज्ड, है ना. मरीज ज्यादा हिलेगा तो आपने ग्राफ्ट लिया होगा, वो ब्लो आउट कर जाएगा. सो प्लीज रिमेंबर ऑल दीज थिंग्स. एंड अब again, because you have taken sutures, because a cannula was placed there, it is possible कि वहां पर कोई क्लॉट प्रोपगेशन हो रहा हो. इट इज वेरी कॉमन. सो आपने पेशेंट को ECMO से तो बचा, मतलब ECMO से ठीक कर लिया एंड पेशेंट बच गया, एवरीथिंग, but you see suddenly patient collapsing on day 2. Why? Because maybe you have not been mindful of the fact कि patient में कोई clot generate हो रहा हो at the site of the vessel. So always, once if there is no contraindication, you please start the patient on LMWH. That is going to take care of any clot formation tendency. So remember that what is ECMO? Once you have started the initiation, ECMO cannula डाल दिया, initiate कर दिया, it is hours and hours of boredom. कुछ करना ही नहीं है, टॉर्च लेके बस मॉनिटरिंग ही करनी है, सब कुछ देखना है. But it is hours of boredom interspersed with moments of adventure. And moments of adventure will be there. So you have to be ready for that, and so that it just remains an adventure, not a nightmare. Okay? Thank you very much.
Thank you, ma'am, for live presentation. And
Shikha, it was a wonderful presentation. Just want to share one. I think there's a difference in how we do it as compared to the international practice. So they always do. So cannulation is one of the most important steps in like initiating ECMO. I mean, obviously the physiology is jeopardized and the patient is obviously very sick, and the team has made a decision that the patient needs ECMO. So cannulation is one of the foremost or the most one of the steps where you don't want to aggravate or create more injury. So how the Europeans do or the international practices, they always do the cannulations in OT. So they always have a surgeon at bay. And the other thing is what I have noticed, because I keep asking how they do. I think the international or the European or even the American practices, they always do it fluoroscopic guided. As they are putting the dilators, the sequential dilatation is always in the live fluoroscopy, so that the kinking of the wire, which is actually very, very common in experienced hands. And if your wire kinks and if you apply more pressure, I've seen dilators going in the mediastinum, I've seen punctures, so it can happen in experienced hands. But believe me, I think doing it in live fluoroscopy improves your, I think the procedure or gives safety to your procedure, because obviously seeing is believing, and I think it just gives a extra safety to the procedure, because obviously if your cannulation is wrong, everything is wrong, because obviously ACMO is flow. Just wanted to share this. Thanks.
If we have transesophageal echo, then bicable view is best for VV ECMO, right? In this view, we can see IVC, SVC both. So this view is best if we have transesophageal echo. And for arterial cannulation, we see descending aorta, and this view we can see guide wire. We cannot see the cannula obviously, but we have see the guide wire. When we confirm the guide wire in descending aorta, then it's okay and we can proceed for femoral artery cannulation. Okay. If transthoracic echo, if you are going for this, then subcostal view, we can use this view for venous cannulation. Obviously, we see the guide wire in intrahepatic IVC, and after that we can cannulate. But for RA, we can go with RA inflow and outflow view or parasternal inflow view. So this view can see the guide wire in RA. Thank you, ma'am.
Did I take a lot of time? Didn't ask.
A lot of stamina. That was very good.
Requesting Monica ma'am, Vinita ma'am, Dr. D. Himanshu sir, and Kausal sir, please take seat on the dais. Good afternoon, all my teachers and seniors. Teachers and seniors are our guiding pillars. No can break bond between teachers and student. It's our honor to have our head of department, Monica ma'am, and our respected teachers. Requesting Monica ma'am kindly come on the podium to enlighten us and address the gathering.
A very warm good afternoon and welcome all of you for this wonderful workshop. I would like to first of all congratulate my team, the organizing team, Dr. Raman, Dr. Rati. Yes, Karan, I can't see Karan. He was also one of the very important part of the start, Dr. Ambuj. I'd like to welcome all the people who have come from outside, all the people who have given their valuable time, the speakers, and welcome all. I can see more of my own department faces, so it's very nice to welcome you all. Well, ACMO is definitely the upcoming modality which everybody would like to learn. And our USP, what we want to put across is that we can do it in a cheaper and a much better way, in being a government institution. So it would be very nice if you could all learn, percolate it all over. Thank you.
मैम फेलिसिटेट कर दिया था बहुत अच्छे से उसे. Requesting all organizing team, please come forward and honor Monica ma'am with memento.
I should felicitate them.
Requesting Monica ma'am kindly felicitate Kausal sir.
Wow, you should felicitate. Come. Who's taking the picture?
Requesting Monica ma'am or Kausal sir kindly felicitate Monica ma'am.
Come. Okay. You've done all the hard work.
Requesting Monica ma'am, Vinita ma'am and Kausal sir kindly felicitate Dr. D. Vasu, sir. Requesting D. Vasu, sir, kindly felicitate Dr. Ramos. Requesting Kaushal, sir, kindly felicitate Dr. Shashank. We have expert speakers at home, Dr. Atihar sir, Dr. Sikha ma'am, and Dr. Raghav. So requesting Monica ma'am, kindly felicitate Dr. Atihar sir.
Thank you so much. Actually coming here, it's my first time at KGMU. Thanks.
Requesting Monica ma'am, kindly felicitate Sikha ma'am. Requesting Monica ma'am, kindly felicitate Dr. Raghav. Ma'am, senior consultant in Midland. Requesting Vinita ma'am, kindly felicitate Dr. Apurva. Dr. Ram, would you like to give vote of thanks?
I'll just take this moment to say something. So, I thank both Raman and Pradeep for actually organizing this, along with Amit, along with Ambuj and Amit. Amit is also sitting now, he also joined here. So, I guess there are a lot of students out here. One of the things that you have to learn is what they've been teaching. It was a very nice lecture. Having said that, one of the most important things is selection of patients. 99% of the times what we do is we start rushing into things when the things start falling apart. And 99% of the times we fail just because of that. You might put best of the best lines, you might put best of the best things, you might say everything, but if you do not select your patients properly, you are not going to get the best of the best outcomes. You pointed out that in US and in Europe, you do have both the OT ready, the fluoroscopy ready. 99% of the time in India, we actually start jumping when the patient is at actually SpO2 60 and you do not even have the option to put a TE. Forget about anything else. You can't even shift them from the place to the next place. This happens for most of our interventions. I'm saying this, the anesthesia team, the catering departments where the patients are, they should all be in sync. The cardiology, the medicine, the respiratory medicine, they all have to be in sync. When do you raise the call? When do you send the team? When do you activate the team? That's something which is very important. Even here, whenever we have selected patients, what happens is by the time they're taken onto the table, when you start putting lines, you are actually not going to help or the patient passes away on the table. So please, along with this, learn this and try to, and each area, there's a difference between guidelines and SOP. Can anybody tell me what is this? A guideline is meant for everybody. SOP is for that place. You have to see what is your place. KGMC में एक बिल्डिंग उधर है, एक बिल्डिंग उधर है, एक बिल्डिंग उस कोने में है, तो आपका SOP उसके हिसाब से होगा। PGI में अगर एक ही बिल्डिंग में है तो उसका SOP उस टाइप से होगा। शिफ्टिंग कैसे करना है? You cannot take A and put it. You cannot put an apple in an orange box and start saying that you are doing the same thing. I wanted them, and it's a very nice program which is being conducted. I also wish that taking it further, we develop the SOP, how to take, when do you raise the call, when do you say this patient has to be taken, when do you start actually counseling the family, because the family also has to arrange money for actually taking them onto ECMO. आप आखिरी मोमेंट बोलते हो कि आपको पैसे की जरूरत है, वो भी इतना, तो घर वाला जब तक पैसे लेके आ रहा था तो मरीज जा चुका होता है. This happens with everything, even for simple things like CRRT, when we started, each one line costs 40,000. The patient has to, even a person who has money, he still has to go out and take it out. So please create the SOPs, and so that we can help the patients at the end of the day. ये हमारे लिए नहीं actually देना चाहिए था. It should have been for you guys. We just came in here. हमको क्या देना उसमें? The speakers and the organizers उनके लिए है felicitations. हम लोग तो बस आए हैं, जा रहे हैं, ठीक है? So congratulations, and I hope this yields something good, and I'm sure it will. Thank you.
Good morning, everyone. I thank our eminent speakers, Dr. Atihas, Sikha ma'am, Dr. Raghavendra, Dr. Apurva, and everyone else for participation and teaching us valuable things about ECMO. I thank our delegates for actively participating, and I certainly thank Monica ma'am, D. Himanshu sir, Kausal sir, and Vinita ma'am for helping us out in organizing this conference. Thank you. अभी एक लेक्चर है, we have one lecture. After this we will have lunch in room number 106, and the workshops will be held in Department of Anaesthesiology.
So we are going to move our last lecture of this CME. So troubleshooting and complication of ECMO. I would like to invite Dr. Raghavendra, he is consultant in Midland. Welcome you.
Light off करना सर. Light off करना.
Good afternoon to one and all, and thanks to the organizing committee to inviting me here as a speaker. The today last class of the lecture is ECMO complications and troubleshooting. So basically, what is ECMO? ECMO is a blender between the man and machine. So any complications will occur that may be either machine related or patient related. So whenever any complications will occur, first we have to note what is the technical issues. Technical issues are very easy to treat, and if you not treat properly, that will lead to the catastrophic complications. So I think all of you previously discussed the components of ECMO and all. So I will briefly discuss about this one components. So this is a console unit, this is a drive unit, and this is a pump of the ECMO machine. See, these all are machines works like a heart. And blender, oxygen, and sweep gases are there, and oxygenator is there. So these are works like a lungs. And third thing, cannulas are there. There are the return or drainage cannula, and the tubing connectors are there. These are works like a vasculation of the human body, either venous system or arterial system. So I told the complications are either patient related or ECMO machine related. So if you patient related complications, that may be either related to the at the time of the initiation or during the ECMO or at the end of the during the decannulation also. So types of ECMO are VV or VA ECMO. The complications are different for the both the therapies of the ECMO, and some are common to both the therapies. If VV ECMO, the most common are the recirculation, hypoxemia, hypercapnia, and hypotension. And in case of a VA ECMO, that may be either oxygen-related issues like differential hypoxia, as ma'am is told about North-South syndrome, and Harlequin syndrome, and hemodynamic issues like LV distension, loss of pulsatility, and vascular issues like limb ischemia, stroke, that may be either ischemic or hemorrhagic, and hemolysis issues, that may be either VV or VA ECMO. And some other issues like flow issues and hyperfusion, oliguria, accidental decannulation, etc. And machine related, like we are using for machine, we are using a cannulas, like catheter related, like a kinking of the cannula or thrombus in the cannula or migration, and a decannulation from accident. So machine related, like failure of any part of the ECMO machine, that may be failure of the display unit. Sometimes electricity will bend, so there is a failure of the display to display the what is the RPM, what is the flows and all. And heat and cooler unit is there. There is a failure of that one that leads the patient will in a hypothermic, and a failure of the pump that causes a and circuit rupture, circuit clots in the circuits, and oxygenator failure, and connectors. There is a leak in the connectors, so there may be air embolism also. So we have any complications occur, just we have to divide itself, whether it is a patient related or machine related, and approach accordingly. And then that is we can manage very better. Otherwise, you will become a very catastrophic way to how to manage and all those things. So according to the ALST guidelines, these are the most common complications. Like this is a renal replacement therapy is the most common. This is around 29, around 30%. Next to that one is a surgical site bleeding. That is any if you done any interventions on the ECMO patient like a tracheostomy or maybe cannulation site bleeding is the second one, and hemolysis, circuit component, clots. These are the relative incidence of the complications on the patient on ECMO according to the ALST guidelines. So common problems during the cannulation. I will start from the during cannulation, at the initiation, and during the ECMO run, at the end of the ECMO, so that we will remember easily. At the time of initiation, what will happen basically? So we are preparing all the surgical checklist and all. So to prevent any complication during the time of the initiation, we have to keep a checklist. One person should be for that one, check just tick, this one is done, this one done, this one done, so that you will not miss anything. So we have to arrange everything, need the dilators and ultrasound machine, all those things, and you have to take all the aseptic precautions. So if you're taking all these precautions, you can prevent the infections during the ECMO run later on also. So we have to know the anatomy very better. So then only we can approach the correct guiding and all. And we can use the ultrasound guidance of measuring of the vessel size and all. So you can choose the appropriate cannula size also. So by this, we can prevent difficult cannulation at the time of the cannulation. And at the cannulation, you put a guide wire, there is a risk of arrhythmia because you are touching SA node and heart. So there is a risk of arrhythmia. And vessel injury, as there is a risk of a perforation of the vessel. In pseudoaneurysm, this is a delayed complication, not early. And retroperitoneal bleeding is one of the complications in case of the during cannulation. And sometimes there is in case of a bilevel cannula, there is a risk of a cardiac tamponade also, perforation of a heart and all. Sometimes during the cannulation, there is a risk of a cardiac arrest also. So during any cannulation procedure, we have to stabilize the patient first, stabilize, increase the vasopressor support, increase the ventilator support, and keep a crash cart ready, and keep the blood and blood products ready in hand. Because what happens during the initiation, whatever the blood, patient blood is there, that will come out of the body. So at that time, initiation, patient will end up in the hypotension, and there is a risk of a cardiac arrest also. So stabilize the patient before taking on the ECMO. By that, we can prevent the complications also, correct the acidosis, increase the ventilator supports, increase the inotropes and vasopressors, and keep the blood products. In case of some, during the priming also, we can use the colloids also. If a patient hemoglobin is less than 10, prime with the PRBCs. And if albumin is low, prime with the albumin. So that is called a colloids priming. Another one is a crystalloid priming. Usually colloid priming you can do in case of a pediatric neonates. So after cannulation, you have to dressing of the cannula sites with a transparent sheets so that we can see whether there is any surgical ooze or any kinking in the lines. So you have to keep the lines along the axis of the limb. So we can prevent, except in case of the head you can just rotate that one. So this one is a drainage and this one is a return. This one is an arterial distal perfusion cannula. This is like this. Post cannulation, what will happen? After the cannulation, there's a flow will be low. That will be flow issues like flow will be decreases, and hypoxia patient, that may be either VA or VV also, and hypercapnia and hypotension after initiation of the ECMO. So oozing from the cannulation site. So these are the post cannulation issues. We'll see one by one. Before that, if any, first I told rule out the technical issues. So technical issues are very easy to treat. First the thing, any hypotension is there, flow issues is there. So hypoxia is there. First you have to see the calibration, whether the pulse ox is connected or not properly. If you are correcting everything, pulse ox is not connected. And second thing, hypotension is there. Zeroing is properly done or not, for arterial testing or not. So that calibration is a very important. And after that, you have to check for the pre-pump pressures and go for the pre-oxygenator pressure, P2. This is P1, P2 and P3. What is the changes between that one? Delta pressure. And see for the blood flow and sweep BSS rates. And see for the RPM. And check the connectors, whether there is any leaky and that, all those things. And approach, we have to approach in a very systemic way. If any complications happen, you have to recognize early. Recognize early and you have to judge whether you have to intervene or not. If some staff will come and say that the SpO2 is around 80%. SpO2 number is not just a matter. We have to accept SpO2 of 75 to 80% in VV ECMO also. So you have to accept, no need to intervene. We have to want to keep a SpO2 of 100%. Just you have to recognize and judge whether you have to accept or intervene. Second, immediate management. If hypotension is there, you have to manage immediately. Otherwise, patient will end up in a cardiac arrest also. So, immediate management. Third thing, diagnose. After management of immediate, don't leave the patient like that. So, we have to rule out why that was happened. What is the root cause for that one? Next, manage the definitive cause. If there is a hypotension, that may be because of some other bleeding in that one. So, definitive management. So, approach like that. So, your patient will be better. So first one is the flow to the approach issues. Approach to the flow issues. Like that, I think most of the things are covered by the Shikha ma'am. So it is she made it easy for this topic for me. Flow issues like that, what is happening here? Anyone? So shattering is there. Excellent. What about this one? This is the external. This is the ECMO circuit. This is I told you, someone has told a correct answer. So this is the opening of this central cannulation. In that one, this is also chattering. Why it is happening? Why the lines are moving and all? And patient saturation is the lower side and blood flow is dropped to 2 points. What will rule out? So this is a chattering because of. So this is a. I think this is not a clear. Whenever chattering is occur, what we have to do first? Decrease the pump flow. Why want to decrease the pump flow? Decrease till that chattering will stop. Otherwise, what happens? Usually flow issues will be lower side. We will increase the pump flow. What happens? More negative pressure. That will suck the more air. So there is a risk of air embolism also. So we have to decrease the pump speed till that chattering decreases. Then we have to give the fluid boluses. Crystalloids or colloids. Colloids are most preferably. And immediately what you have to do? Decrease the pump flow and give the fluid boluses. And rule out the cause. What is the cause for that one? If a patient is asynchronous breathing is there with a ventilator, so we have to sedate and paralyze. Hypovolemia is there, bleeding. Rule out the cause for the new onset of sepsis. This is very unlikely in case of the initiation. And hypoproteinemia, give the albumin. Cannula wall position, is there any kinking of that one? See, keep the cannula position properly. And check for the patient position also. There is any bending of the knees and neck kinking and all. So you have to keep up properly. Like sedate and paralyze in case of asynchronous breathing. Colloid boluses, most commonly can albumin if less than 2.5 and give the pair basis if HB is less than 8. And check the cannula position with help of a Doppler, ultrasound and X-rays. And keep the neck in a neutral position. And if in spite of all these things, this one is not managed, then go ahead with a dual cannulation for the drainage. We can put another cannula for the venous drainage. So we can get a flow will better. And in later onset, there will be a sepsis also. Because of a sepsis, there is a hyperdynamic circulation. And send for cultures and get a serum procal and CRP and correct that one. Escalate the antibiotics. And second issue is what is happening here? Same RPM, flow will be low. So again, first of all thing, we have to rule out the technical issues. What are the technical issues and all? We have to correct the flow sensors and all those things. Check the vitals and see for any kinking of the circuit and manage accordingly. And check the circuit pressures P1, P2, P3 and give a fluid boluses and increase RPM. Whether we have to accept or not or intervene. See for the pre-pump pressures. If a pre-pump pressures are the more negative, give. That means patient is a hypovolemic. Then cannula wall position. Is there any kinking that one? Correct that one. And if there is an increase in the delta pressures, that means an oxygenator failure. And both pre and post oxygenator pressures are high. That means patient afterload is high. The SVR is higher side. And any kinking of the cannula, that is return cannula. So correct that one. And if all pressures are normal or decreased, that means obstruction in the pump. So I think if a hypovolemia, fluid boluses, most colloids and cannula position check with help of X-ray or Doppler and repositioning accordingly. And keep the neck position neutral or limb position normal. And check for the post-oxygenator ABZ. If that one is any change, post-oxygenator ABZ will be showing the low hypoxia and also change the oxygenator also. And see for the signs of the hemolysis. And if that one is there, see increase the ACT values. ACT value should be higher side. If a negative pressure, pre-pump pressure is there, how to approach that patient? Like a chartering is there, tube and all, how to approach? First, you have to load the technical issues I told already. So calibrate pre-pressure line blood. If any blood clot in the pressure lines, just remove that one. And after load the technical issues, go for the patient related. If a sudden negative pressure that caused because of a kinking in the circuit or kinking in the cannulas or cannula malposition, correct all these things. If a patient with a not constant flow, that patient is agitated, patient is asynchronous breathing at all, sedate and paralyzed. If a gradual causes are there, the hypovolemia or cardiac tamponade may be or secondary to the pneumothorax also during the cannulation. And rule out the pericardial effusion also. And cannula size is small. Gradual flow decreases, that may be because of cannula size is small. So we can put another drainage cannula. So this is a systemic approach. You have to approach like this, then it will be very easy to manage the flow issues. Next is approach to the hypoxia and hypercapnia. So before approaching the hypoxia and hypercapnia, just you have to see the patient vitals. Whether that hypoxia is causing any vital hemodynamic stability or not, what is the clinical scenario? If a patient is awake ECMO, see the neurological status. And see for the urine output and lactate levels. Is there any hyperlactemia and all those things you have to note? And I told already, the desired pivot in case of VA and VE is more than 50, SpO2 should be more than 88%. But acceptable is more than 45% of PO2 and SpO2 is more than 80%. You don't need to achieve 100% of SpO2. So numbers are only hard and fast. If a patient have a VV ECMO, the some factors will decide the SpO2 level on a VV ECMO. Like there is a two circulations. One is the ECMO circulation, one is a native circulation. ECMO circulation factors are the ECMO flow, ECMO FiO2, oxygenator status, and recirculation on VV ECMO. And native circulation, patient cardiac output, like ventilator settings are there, most of the patients on a rest ventilator setup, FiO2 and PEEP and lung status. So ratio between the ECMO flow and cardiac output. So if that patient is a SpO2 on 71% on Vivo ECMO, how to approach? First, you have to see whether that is we have to intervene or not, whether you have to accept or intervene. Rule out the technical issues, see the pulse ox probe connections and all, and tube color. As ma'am is told already, tube color you have to check for the whether drainage and return cannula, whether that is in the same color or not. And flow or FiO2, whether that is oxygenator is connected or not properly with the help of a flow sensor. And check for the vitals, increase the ECMO flow and increase the ventilator setting. If issues with the ECMO, if any complications with the ECMO you saw, oxygenator is not functioning properly. So then what you have to do? Increase the ventilator setting of the patient, because most of the cases patient on ECMO dependent on ECMO only. So that time you have to increase the ventilator settings and increase the if patient is not on allotropes and vasopressors. First, any complications occur, divide yourself among the like a team. 3 members should be see the patient and rest of the members should be see the ECMO machine. So patient should be managed properly. So they will increase the ventilator settings, inotropes, and if sudden hypoxia is there and both drainage and return cannula are dark color, so that may be because of a sweep gas failure, blender valve function, oxygenator failure. Both are bright, that means recirculation, because this is a VV ECMO. And flow issues, we have to correct that one. And if there is a patient is an increased metabolic activity or awake, give the some sedation, or if need, give muscle relaxants also. And if air passes obstruction, like in case of trachea and all, mucus plug is there, do the bronchoscopy and remove that one. If a gradual hypoxia, then associated with increased delta pressure, that means oxygenator failure, change the oxygenator. If parenchymal worsening, that may be because of a disease progress and fluid overload, effusion, pneumothorax, treat accordingly. Like I told, check gas connection, decrease flow, correct the cause, sedate. If a patient is irritated, beta blockers will also help. And therapeutic bronchoscopy, if any mucus plug is there, just X-ray ultrasound to rule out any parenchymal worsening, post-oxygenator status, if needs, change that one also. And refractory cases, you need to target HB higher side more than 10. And some cases you need a hypothermia also. But hypothermia will not do because of patient risk of there is arrhythmias and coagulopathy and drug-altered metabolism. So, Vivek, how to approach? See the tube color, same color. Dark color if a gas flow failure, same color, that means bright. Both are dark, gas flow failure, both are bright, that means recirculation. See for the technical issues, pulse ox connected or not properly. And flow, whether decreased flow, kinking, hypovolemia, small size cannula, so put under drainage, pump or oxygenator clogging. So, wrote all these things in case of a flow. If high demand, that may be secondary due to the restless, agitated fever, sepsis, treat accordingly. See for the delta pressures and post-oxygenator and ABG. If that are increased, that may be oxygenator failure. And X-ray and 2D echo to see the parenchyma of the lungs, manage according to the cause. And increase the supply and decrease demand to manage hypoxia. So I told hypoxia, that may be because of this is a sweep gas failure. This is sweep gas failure, that will determine the CO2 elimination. And oxygenation determined the FiO2. I told already manage according to the treat the cause, increase the supply and decrease the demand, like sedate, paralyze. Technical issues you have to treat and you have to correct the oxygenator failure, change accordingly if need that one. Recirculation you have to manage, improve the parenchymal functions. I told this one like, what is this is a normal color in case of a patient on a ECMO. This one is a drainage, this is a return. Both are bright, that means some recirculation is there. So this is the drainage and return cannula, proximity is very low. So what happens in case of a recirculations? So this is a drainage cannula, this is return cannula. The difference is very low. Whatever the return cannula coming, that is oxygenated blood is going to again drainage cannula. Only around 20 to 30% going to the patient. That may be because of a cannula configuration, positioning of the patient, pump speed, cannula size, and changes in the intrathoracic and intracardiac and pressures. Direction of flow. So this is because of recirculation. In case of refractory cases, first the thing you have to load the cause and repositioning of the cannulas. And refractory cases, you have to put another drainage return cannula to the patient. Like if this is a bifemoral, like a femoral, you have to put another return cannula to the patient. So another one is the recirculation fraction is there. You have to calculate this according to this formula. You have to calculate whether that one is a need. Then you have to correct that recirculation pattern. How to improve the parenchymal functions? First one is do the bronchoscopy. If need any mucosa plug are there, and do the tracheal lavage. Take a ball and send for the cultures if need a signs of a sepsis are there. And in case of the patient on ECMO, you can do proning also. So many will think that don't do the proning on the ECMO patient, because what happens during ECMO patient, if you don't do prone, there is a kink of the cannula, so you will not get adequate flow also. But we can do proning. I'll show the videos also. And if a parenchyma is the overload is there, give the diuretics, make the lungs dry. And we can do the lung recruitment and chest fissure and all those things. And if there is any collection is there, then you can put ICD. So this is one of the right bronchi is the blockage is there. So after that one done a bronchoscopy, we got some collections here. So you can do proning on ECMO also. So the main thing on VV ECMO is most of them will say give rest to the lungs. Rest ventilator settings, but don't make them lazy. Is it? So these are the ECMO. There are so many patients on proning. Do the active physiotherapy. You put a lateral position on the ECMO. Positioning is also very important. So this is one of the video. This is the mobilization of the ECMO. Patient on ECMO. This is mobilization. See how all the team members are taking care of that patient. One person is holding the ECMO machine. One is the cannulas. So after that hypoxia, we have to go with a hypercapnia. Hypercapnia is decided by this one, oxygenator, a swift gas flow on VV ECMO. C for the tube colors. So again, first of all, rule out the technical issues. Swift gas connected or not. If that one is not there, just do that one properly and increase the swift gas flow. And if that one is also connected, then increase the ventilator settings. If issues with the ECMO machine, if there is a swift gas failure is there, we have to correct the ventilator settings. And sometimes they will say the permissive hypercapnia also. If it is the time of the initiation is very low, hypercapnia will occur at the time of the decannulation or the weaning process. Sometimes at the time of the decannulation or weaning process, hypercapnia can accept. That may be because of a permissive hypercapnia and all. But nowadays that is also absolute. Only hypercapnia is there, so that may be because of a blender malfunction. Overload that one. And central oxygen connected or not, just see that one. And membrane edema, just flush the membrane oxygenator with help of a oxygenator flush. Associated with hypoxia and hypercapnia is there. That means you have to rule out both are dark, both are bright. If there is increase in the metabolic activity or parenchymal worsening, treat accordingly. So again, we have to hypercapnia treat with a swift gas filler changing and flush the oxygenator with a 15 liter per minute swift gas for 20 seconds every 4th hourly. We have to inspect that membrane gas. If there is edema or swelling in that one, just flush that one. And manage the recirculation and correct the cause, sedate, paralyze, and give the beta blockers also. And if needs, a change oxygenator. If patient on a VA ECMO, hypoxia and VA ECMO, how to approach? Again, first thing is rule out the technical issues and probe is connected or not. See the tube colors. Both are color is good. Then rule out a major ECMO related issues. Flow and FIO connected or not. See for the vitals. Along with hypoxia, hypotension is there or tachycardia is there. Just rule out that one. If hypoxia and VA ECMO, we can increase the ventilator settings. If this is the most common hypoxia and VA ECMO is, as ma'am told previous class, hypoxia and VA ECMO. Harlequin syndrome. We'll discuss about that one later. We have to see hypoxia and VA ECMO, that is whether whole body hypoxic or only regional. Whole body hypoxia means both are venous drainage and return cannula done. That means swift gas failure or oxygenator failure. or increase in the delta pressure, that may be because of an oxygenator failure. So differential hypoxia. So most common cause in the hypoxia during VA ECMO is oxygenator differential hypoxia. As told ma'am previously, heart is improving and lungs are deteriorating. For that one reason, right upper limb and head become a blue, rest of the part become red in color. You will not get clinically, you will see the ABC parameters and all those things. You have to treat the cause accordingly. Hypoxia is there, connect the gas connections, change the oxygenator if need, and for oxygenator failure, check for the post-oxygenator ABG. More than 2, it should be, post-oxygenator ABG should be 200 to 250 millimeter of mercury. If less than that one, that means oxygenator failure, change that one. And if oxygenator failure is there, then that times you have to increase the ventilator settings. FiO2 you have to increase, and you have to keep in a 88 to 90% or 75 to 80% like that. And sometimes need a therapeutic bronchoscopy also. This is Harlequin syndrome, also called differential hypoxia, also called north-south syndrome, also called coronary cerebral hypoxia in case of VA ECMO. What happens? From SVC, return blood, right heart, lungs, left heart. There is a, basically this is a native circulation. ECMO is having a 2 circulation. One is the native circulation, another one is a ECMO circulation. What happens as a heart is get improving, and this is from descending aorta, this is ascending aorta, this is ascending and descending. The ECMO flow is coming from here, and this is native circulation. So what happens? There is a flow competition in the aorta. So heart is improving, ECMO flow is also increasing. What is the management for this one? Exactly, decrease the ECMO flow. So this one is getting a deoxygenated blood, this part of the body is getting oxygenated blood, flow competition in the aorta, recovering heart versus ECMO pump. And blue head, red legs, this is one of the synonyms. And for that reason, we have to measure SpO2 on the right side of the body. So we can detect early. If you put any probe or pulse oximeter on the left side, you can't detect this Harlequin syndrome will get missed. So try to put any catheters or pulse oximeter on the right side. And you have to measure both hands, right upper and left upper limbs. If persistent hypoxia is there, then you can shift towards the VVA ECMO. That means heart is improving, no need of a VA ECMO, convert into VV or additional return cannula, VVA. If Harlequin syndrome is there, approach I told already this one. Rule out again technical issues, tube color, FiO2, increase the ventilator settings. So differential hypoxia, I told already this one, the heart improving, lung are deteriorating. So sometimes there may be need of a impel also. If a patient on hypotension and VV ECMO. Again, hypotension and VV ECMO, rule out the technical issues and whether during done or not properly, because of calibration is a very important. And see for the flow and pre-pump pressures and give with the IV fluids. If there is no response, go with the vasopressor support. These are the immediate management. And hypovolemia, and that is detected with help of a tube chartering, and pre-pump pressures are more negative, give fluids. If bleeding is there, look for occult bleeding in the GI tract, GI bleed, ICH, retroparental bleeding, look for the bleeding, occult bleeding also. And sepsis, see for the sense of a sepsis. So because of sepsis also patient become hypotension. So see for the cultures. Usually most of the patients on ECMO will not get fever. Why? Why patient on ECMO will not get fever? Because extracorporeal circulation is managed with a heater cooler unit. Is it? That will maintain the temperature, so most of the patient will not get temperature. So that reason you have to see for other things like TLC, CRP, Procal, and send for culture, escalate the antibiotics according to the microbes. If temporary effect, rule out that one. Acidosis, and correct the acidosis. Acidosis causing a hypotension, so correct that one. Whether that may be either metabolic or respiratory. If cardiac failure is there, treat according to myocarditis and right heart failure. Usually fluid bolus is 15 ml per kg, and give the colloids And you can get a tag also or rotate so that any coagulation derangement is there, give product accordingly. And give this one inotropes and vasopressors and cultures, escalate, accelerate, already these all things, and give inodilators and inotropes also. So if a patient on a VECMO, hypotension occurs, how to treat that one? First one is again same, rule out the technical issues and increase the ECMO flow. If hypotension on VECMO, increase the ECMO flow, and if patient is volume depleted, give the adequate fluids. Inadequate cardiac output, that may be because of a native or ECMO circulation. Cardiac stunning is occurs, low pulse pressure or hypovolemia or poor LV functions. We have to correct with the decreasing the pump or give the impel also. And peripheral vasodilation because of a vasoplasia and because of a septic shock, you have to treat. Initially, whatever happens after starting off a ECMO, there is a surge reaction. So that is acceptable. After that one, there is a not acceptable. So you have to treat accordingly. What happens if a patient is on a hypotension with hypoperfusion? Lactate will get rising. So you have to see mean arterial pressure and lactate. Manage with increasing the ECMO flow, target lactates and maintain the pulse pressure more than 10 mm of mercury, and manage with the fluids, colloids, and use inodilators, milrinone, dobutamine, adrenaline, and fluids and vasopressors, and give send cultures and escalate the antibiotics. And sometimes there is a vitamin C, methylene blue in case of a vasoplasia, and correct the isolysis with a bicarbonate. And bench is to see the hypotension, hypoperfusion, you have to target the lactates. Lactate is one of the marker that is the trend of lactate is very important. See, this is one of the study that is showing that survival is more than 30 days. If lactate is, you can keep a lactate lower side, then survival will be increases. Lactate dynamics is very important. And next is the vascular complications. First is bleeding. Bleeding will occur at a local site or systemic. And limb ischemia, specifically in case of a VECMO. And hemolysis. These are the vascular complications. What is here? This is a tracheostomy site. There is a local bleeding. So what we have to do? We have to see whether that bleeding is first compress if it is accessible. Open bleeding is a compress and give fluid boluses and correct hypotension. Blood transfusion, get a tag also, thromboelastography, and see for the coagulation derangement and correct accordingly. Give the blood products. And local bleeding is the cannula site, GI bleed, or pulmonary hemorrhage, IC bleed, surgical bleed, you have to manage. If generalized bleeding is there, you have to decrease the heparin dose. Sometimes you can run a heparin-free ECMO also. And treat the sepsis. Because of sepsis also patient will bleed. And sometimes hypothermia. Hypothermia will also causes a bleeding. Management, if accessible site is there, compress that site. Local measures like a gut bleeding is there, give a pantoprazole, octreotide, and somatostatin omalox. If surgical intervention, suture that one, and go the endoscopy, bronchoscopy, embolization, sclerotherapy. And if a CNS bleeding is there, give antiepileptics and decompression craniotomy if need. Stop the ECMO, that is a very critical catastrophic condition. And manage the coagulopathy according to tag and all. So this is one of the CNS bleed. So we have to titrate between the bleeding versus thrombosis. If you stop heparin, what will happen? There is risk of a thrombosis. And this is one of the chart, how to maintain the ACT values according to the heparin, how to titrate the dose of heparin. ACT values and repeat that. Second complication is a limb ischemia. This is occurs most commonly in case of the VA ECMO because of a distal perfusion cannula is not functioning properly. And you have to check the limbs every day so that any discoloration in the limbs. So this one is prevented by with help of these are the limb colors. We have to, these connectors are there. This is the NIRS, near infrared spectroscopy. This is the distal perfusion cannula is there here. So we have to see the NIRS. This is the limb ischemia. After correcting this is NIRS, right and left upper right limbs. So we can measure the this one, infarct and the limb ischemia. How to correct that one? So sometimes we need a increase the ACT value, and rarely cases we need a fasciotomy and amputation of the limb also. Regular Doppler will tell us. These are the distal perfusion cannula. So this is, what is this one? Hemolysis. This is occurs in 1 in 5 patients. How to approach? First, the urine colors are dark in color. So check the urine color in the tube. Check the circuit pressures are too negative. Too negative pressure causes hemolysis. Give the fluid boluses because that may be because of hypovolemia, alkaline diuresis. First thing, urine color is a dark color. You have to manage immediately like this. After that, you have to check for the hemoglobin in the urine. That should be less than 0.1 gram per deciliter. And pre-pump pressures are more need to give the fluids. Clot in the circuit, change that one. If increase in delta pressures, that means oxygenator failure. Both the pre and post oxygenator high, that means overload. SVR is higher side, or kink in the return cannula. Or both pressures are normal and decrease, that may be obstruction in the pump. And mismatched blood transfusion, because on the patient ECMO you are giving so much blood product, the risk of blood reactions also high, so there is a risk of blood transfusion that causes hemolysis. So give fluid boluses, again transfuse the PRBCs if there is a hypotension along with that one, and correct, change the circuit if need, and change the oxygenator if oxygenator issues are there, and give the some fluids, and also and keep a ACT higher side if there is any oxygenator or clot in the pump or oxygenator. So some of the renal issues during ECMO will occur. I think this one will discuss in the station. So till that we will study the patient-related complications. Second is ECMO machine-related complications. So I told already this one, no? Catheter-related issues or machine-related. So any clot in the circuits or circuit approach or air embolism, oxygenator failure, pump failure, and connectors leak, or maybe risk of air embolism. So most deadly complications are power failure. I will start with the power failure. How to approach with the power failure? What happens if there is a motor failure or any electricity will go? Battery failure. Most of the ECMO machine will come with a battery backup. What happens in case of some battery will fail, and because of a long run of ECMO, AC power failure, the ECMO machine will start. What we have to do that condition? First, because most of that is depends on the patient, you have to increase the ventilator settings and increase the again inotropes and vasopressors. Stabilize the patient and divide the team among yourself. Some will see the patient, some will distribute towards the ECMO machine. So first thing is call for help, patient management, and hand cranking. One of the hand cranking is kept on the nearby this one pump. So we have to take a patient on a ECMO, and you have to start the hand cranking. And first, previously you saw what is the ECMO flow and RPM and all those things, and start hand cranking according to the RPM. We'll show this one in the stations. And we have to keep the color difference of the tubing and see for the SpO2 and mean arterial pressures. Till that time, if power failure along with that pump failure is, change the pump head. Or till that one power will come, take on the hand crank and change that one. If a patient on a VE ECMO, there is risk of cardiac arrest because everything is dependent on the ECMO. If VV ECMO, patient will end up in a hypoxia. So again, this one I told how to change, how to power failure, how to take this one. We'll discuss this all things in the stations. This is pump failure because of how to see this one. Patient will having a hematuria, hemolysis, Coca-Cola urine. On auscultation of the pump head, you will see the crackling sounds and a sudden increase in the noise, no change in the circuit pressures. Then that means there is a pump failure is there. How to manage that one? You have to again call for the help, increase the ventilator settings, and keep a crash cards ready. 2 teams, one for the patient, one for the ECMO machine management. And if a pump failure is there, 2 things we can do. First thing is you can change the pump head only. Second thing, you can change the whole circuit. Again, both pros and cons are there. If you want to change only pump head, that means patient financially will be very easy. Other thing, if you want to change again ECMO whole circuit, that need a very manpower and financial issues. and there is a risk of a bleeding also there. You have to need a blood products and all those things. And sometimes you need a increase the diuresis with help of fluids and diuretics, and increase the ACT value with help of anticoagulation if not in the pump head. So these are oxygenator failure because of a clot or membranous edema. See, visible clots are there. How to recognize? Patient is having a hypoxia or hypercapnia, or increase in the delta pressures, clot in the fabric, or post-oxygenator ABG showing the POT is less than 200. And PCOT is more than 45 millimeter of mercury. That means oxygenator failure are there. How to manage? Again, same management. We have to manage. Some team of the members will go for the patient management with ventilation and inotrope support, and second team is go for the change of the circuit or change only the oxygenator. So this is one of the clot in the oxygenator. So this one is discussed previously. This one is a P1 and P2. If a pressure drop across this one is a delta pressure is there. If that one is going increasing, that means a power failure, oxygenator failure. So this is how to approach this one, the lung function. And see the pressures P1, P2, P3, and we have to diagnose accordingly and treat that one. So this is one of the decannulation accidental. How to manage? Again, clamp, compress, call for help. We'll discuss about the accidental decannulation during the station. And I told this one is a discuss again previously about the TARS test. We have to surveillance of the lines and oxygenator and pump. So this is one of the video how to change the circuit. If any circuit changes, do that time you have to increase the ventilator settings and increase the vasopressors and inotropes, and prepare for cardiac arrest also. So for that one you have to see the trends with help of a ECMO data sheet. Key to success or complications will occur. That may be patient related or machine related. We have to stepwise approach should be mandatory, and communication with the team members and technical issues you have to rule out again, and vigilant monitoring and watching to the trend. Main is ECMO is a teamwork. Thanks to the team getting and organizing committee. Thank you.
One thing, Raghav, that I would like to mention is that when looking for the Doppler flow in the limb, if you are suspecting that patient's distal perfusion may be compromised and you're looking for the Doppler flow, don't look for the pulsatility. There will be, because pulsatility will not be there. The patient is being managed through ECMO, which is a non-pulsatile flow. You will just be able to locate a continuous flow and a continuous whoosh sound, and not a classical pulsatile flow. Absence of flow means that this thing is lost, perfusion is gone, but continuous flow means that perfusion is there. Pulsatile flow you will never get in a PA. Also, I would like to mention that the ACMO Society of India, it organizes, many of you must be knowing, annually fellowship exam, and last year it was held in December, and the results are out. I think again they'll be holding it in December. There is also plan to hold it bi-annually. So there are two pathways. Either you can enroll as a regular student at one of the ACMO Society of India and those centers, or you can give an entry exam and enroll as an alternate pathway student. And there are many centers, you can go on their website, but you have to pass the entrance exam first. And our center, Regency, it is enrolled as one of the centers, and currently we have a student there. And if you wish, so you can either enroll as an alternate pathway pathway student or a regular student, or even if you are enrolled somewhere with some other center, because our center is a SESOI endorsed center and we send all the data, so you can, during that time, you can come. If the ECMO is running, you can come and visit. And all those visitations and days and hours that you spend on ECMO will be counted, and they will be included in your ECMO program for eligibility of writing the exit exam.
Thank you, Dr. Ravin. And thanks to all speaker and other faculties and delegates for this CME. So we will move for lunch, and it is arranged in 106. And after a half an hour, we will proceed for workstation, and it has been arranged in Department of Anaesthesiology. In front of neurology department, I think मेरे resident guide कर देंगे. तो CCU2 के नीचे है, ground floor पे arrange किया गया है faculty blocks पे. So now we will proceed for lunch.
That is the reason. Actually, she sees क्या करना है, क्या करना है, it's really good. हाँ चल रहेगा, रोटाफ्लू की बात चल रही है हमारे कुछ. वो आएगा फोन आपको, बहुत जल्दी आने वाला है. CSR टारगेट, CSR को फिटर करोगे आप? CSR वाला रूट पकड़ रहे हैं क्योंकि गवर्नमेंट तो सुन नहीं रही.
यहाँ पे जो इधर BHU में हमने करा था, BHU में भी CSR से हमारी
बेशक आपके
कॉन्टेक्ट करा दो पूरा.
हाँ ये सब लेकर नहीं बेशक है. उसके अलावा कुछ और क्रैश हो रहा है, क्रैश हो रहा है. मैं देखा था बट एक्चुअली
It was good. मतलब हमारे delegates कम थे, they were like 30. They were very good. Kiran Solanki came all the way from KGMU. It was very good. यार पूरा तो नहीं है. I can go a little on.
मे भी हो सकता है. सर का अभी थोड़ा बिजी चल रहा है.
तो कट करें.
कुछ और उसका मेरा प्रेजेंटेशन निकाल दोगे आप? मेरा वो चाहिए था. यहाँ आना नहीं होगा मेरे ख्याल से.
अब यहाँ नहीं
रेट मार दूं?